Good morning. Morning, everybody. Get things started, and we have a great morning program, and I'm sure people have flights and are starting to think about getting home, but we'll keep you distracted with the content for a little bit longer. I was giving the AV guys another minute or so. I had just a couple of intro slides this morning. If you can pull those up, that would be great. The morning program, I'm just going to talk for a few minutes, then we have our last keynote speaker. Then we'll have the panel, and we do have some time at the end. Hopefully people don't have to run right away to the airport for some wrap-up discussion. And I have a few prompts for that once we get the slides to get you thinking about that conversation. You guys have the wrap-up slide deck? Thank you. Let's see. Clicker working? Okay. Just a reminder from Dan Cole's presentation about the levers that are available to the APSF for various initiatives. And when we get to the conversation at the end of the day, I just wanted to have you keep this in mind, because we do want to like to end these meetings with some notion of what the next step in the strategy is, what are the things APSF can do, and these are some of the areas that we can think about being effective. We started out with the healthcare challenges as kind of an underpinning for our conversation, and so interested in thoughts on technology and how it can or can't address some of these challenges, and maybe what the barriers and strategies would be to doing so. As you think about weighing in during the wrap-up session, we're going to be interested in audience comments. Some prompts to think about are what you've learned about emerging technologies in healthcare over the last day or so, and how it will inform your own work. What are the challenges to making progress, whether you're a user, a healthcare leader, or a developer of technology? And what are some of the action items for APSF? So as we go through the morning, keep some of this in the back of your mind, and like to return some of these themes at the end of the day when we wrap up. We tried to run this poll yesterday, and it didn't work very well. So we're going to just try to run it again today. There's just a few questions if you want to take a minute and get on. Basically, what prompted these was an answer to one of the polls, I think under JW's panel yesterday, where I think 97% of the audience identified education as a challenge to the introduction of technologies. And so I think I just advance these as we go, right? There we go. So I don't even remember them now from yesterday, but so interestingly, so industry needs help for effective education. Pretty overwhelming there. And it is definitely a role that APSF has played in the past, has sought to play. So great opportunity for partnership. For those of you that are on the Committee on Technology, this is definitely an agenda item that we can put on our meeting in October. So I'll be interested in some comments on that today, and then follow up as well. So the next question, what regulatory requirements should be considered? That's not it. I can't hear. What's that? That shouldn't be the question, but let's just see if okay, here we go. So again, we'll take a minute to respond. So yeah, this is it. This is it. So the choices are regulatory requirements for device education, like the IFU ensure or foster effective education, and regulatory requirements for education reduce the resources available for effective education. So, so interesting. So the regulatory requirements seem to be useful, and I didn't quite expect that when we put these questions together, because my experience is that companies will often say people need to read the IFU when we find out that there's user issues. I find that users rarely do read the IFU. But so this is an interesting one, and also something maybe for some conversation later on. And then let's just go on to this. Yeah, so the most impactful approaches to clinician education. And this also helps to get some guidance on where to strategize. So CME generating materials still. CME seems to be a carrot. Webinars, online educational programs. I'd be interested in some comments later on companies perhaps that have put webinars out there, and what you think the impact is, how impactful you think those have been. So, all right. So with that said, let's move on to our last keynote speaker. Very excited to introduce Subha to you. If you look at the literature on physician well-being and burnout and technology, the electronic medical record figures very highly, and Subha has done a lot of work on this. So Subha Airan-Javia is a practicing hospitalist and informatician at Penn Medicine, as well as a former associate chief medical informatics officer for the health system. She spent the first 15 years of her career researching, designing, and building technology that improves patient safety by helping teams collaborate, which helps reduce preventable errors. As part of her work, she and her team created Care Align, which is a team collaboration platform deployed across Penn Medicine for almost a decade and is now a company, and she is the founder and CEO of that company, while also seeing patients throughout the year. Her mission is to make it easier to provide the safest and most effective care for patients. Please join me in welcoming Subha.
Thank you. Hello. Great. What do I do with my hands if I'm not holding a mic? Oh, okay. Great. Thank you. All right. Well, hi, everybody. I'm really excited to be here today. I think my bio profile gave most of my introduction. But as I mentioned, my name is Subha. I'm a hospitalist. I'm a very part-time hospitalist. I only do a few weeks a year now. But really have spent 15 years focusing on how do we make it easier to provide better patient care through well-designed technology. And as my disclosure, we did take actually work that started for me as an intern, as my quality improvement project almost 20 years ago, which is now a spin out of Penn called Care Align. And so the information I'm going to be sharing is based on this work. It's lessons learned. It's things that we have found has worked in our experience. And really my hope is that you'll be able to take these back and employ them in your own work at your own institutions. So I wanted to start with a few take-home points to just kind of set the stage, which is that, number one, technology impacts all aspects of what we do. It's not just one thing that fits in one box that we touch at one point, and that's part of the point I'll be making here. The second is that technology is a tool, and like any tool, it should help us complete tasks. It depends on who buys that tool, who the tool was designed for, how well the tool was designed, whether it's the right tool for the job. But at the end of the day, that's really what it should be. And that's how we should be looking at it, is how does this technology help me accomplish my task of providing great patient care? Because technology really can be great. I'm sure all of us here have experiences with things in our pockets that we love that are technology, but the key is it really has to be designed well, and it has to be implemented well. Sorry, this happens every morning. And at the end of the day, technology is supposed to work for us, not the other way around, which is how it feels all too often and what I think we need to demand more of. So I'd like to start with a call to action that we should never accept the status quo. We should always be challenging and thinking about how to make things better. It's hard because progress requires change, and change means that you have to change culture, which is not easy. But if we accept the way things have always been done, progress stagnates, and we are letting down not just our patients, but ourselves as well. The good news is that you can have your cake and eat it too. It is absolutely possible to accomplish the goals that we want to accomplish, meaning improve the care that we provide patients, while also having technology that actually helps make our lives easier, helps us do that job, dare I say, bring joy back to the practice of medicine. It is possible. I know it's hard to believe because these are the types of screens that we are typically seeing when we interact with our technologies. Obviously, they're different everywhere, but clearly not very well designed. It looks like they're from 20 years ago, which some of them still are probably. But there are ways to make this better, and we'll walk through what some of those are. So the first is that any process improvement, if we want it to be widely adopted, to scale, and to be sustained, has to involve people, process, and technology. All too often, a lot of our quality improvement work is people and processes with a lot of really great interaction and innovation between them. And then technology is not an afterthought, because I don't think it's our fault that we aren't thinking about technology, but it's really not a tool that's made available to us to be able to work with in our quality improvement efforts. And because of that, we really miss out on making that last mile of effectiveness with any of our projects, because really technology should not just support the people and the processes that they're doing, it should catalyze things. It should make it possible for us to do things that we can't otherwise do without the right technology to support it. Process improvement, especially with technology in mind, has to be a constant iterative cycle. It is literally never done. We have releases on our platform even before the spin out, probably every month. And that's because workflow is constantly changing. Things are constantly improving or getting worse. You learn new things. All too often, I hear a lot of information systems department leadership saying, oh, well, we built this thing, we're done, let's put it on a shelf. It doesn't work like that, because very quickly your clinicians will move on to new workflows, and then you have technology that's outdated again. In this figure, what I really like how it puts things together, because at the start, when you start any of these processes, it's defining the problem. So countless times I've had people come to me and say, I want this thing, please build me this thing. Well, that's not the problem I'm trying to fix. That's the solution that you're asking me for. And if you apply the 5 whys of quality improvement to technology design and process improvement, it's very effective to help us really identify what is the real thing that we're trying to solve for, which then enables us to design solutions for it. So the next step is not, okay, we have this problem, let me think within the confines of what's possible in this piece of technology and build it, which I have done development that way. It does not work well. But rather, let me wish for the pie in the sky and say, what could a potential ideal solution look like to solve this problem? And then we work our way backwards from there to figure out how to actually accomplish that. You then need to think about how you're going to measure what that success is. You devise your solutions, which, as I mentioned, is people, process, and technology. You do small-scale testing, and then you scale up. And notice in all of these, technology is really important and essential to the process. Unfortunately, our systems don't make it, our current systems and legacy systems don't make it easy for us to do that, which is why really, I think across the board, most of our technologies have not kept up with the rapid way that the way we deliver care is changing in medicine, which is why, as we've talked about, we're very frustrated with how our systems are not helping us do our jobs. This is a study that was released just last month, showing that overwhelmingly clinicians felt like the EHR was not helping them provide care. It was not helping them efficiently accomplish the tasks that they need to do. I would consider that a failure of a tool doing its job. We also know that burnout is directly tied to satisfaction and experience with the EHR. There's obviously many different things that contribute to burnout, but frustration with our technology in our EHR is absolutely a big part of the burnout that people are feeling. And then we also know that burnout has a lot of consequences. So one of them, as we talked about, is people are leaving. This study, which I really like the way they've looked at these results, breaking out the likelihood of someone saying that they're going to leave medicine versus reduce their hours, broken down by people who feel burnt out versus people who feel valued in their healthcare system. And the bottom line is people who identified as feeling burnt out were more than twice as likely to say that they're going to reduce their clinical hours and their clinical time. And the bottom line take-home points of that study were that 1 in 3 frontline clinicians across the board said they were going to reduce their work in the next 2 years, and that 1 in 5 physicians, 2 in 5 nurses were going to leave medicine altogether within the next 2 years. So it's really striking. I think we've always had challenges with our workflow, but it's really feels like it's coming to a head. One of the other consequences of burnout is that we make more mistakes. It's like this vicious cycle that we make more mistakes, we get more moral injury, we get more frustrated, but this is a real consequence and a real problem, especially as we're all talking about how to improve the quality of care that we provide. This study, which came out in January of this year, talks about, just looked at how many errors were happening on the inpatient setting. And they found many of the things that have been reported and validated studies from years past, which is that 1 in 4 patients have an error occur in the hospital. 1/3 of all errors are preventable. And 1% of all admissions have a serious adverse event happen, which is preventable. And you'll notice in all of these slides, these QR codes will take you to the study itself or to the PubMed article so that it's easy to find. So just for context, that 1% metric, there's 33 million admissions in the United States every year. That means over 333,000 people are having serious, or at least admissions, are having serious preventable adverse events occur, which on a daily basis is the equivalent of 2 fully loaded 747 jets. We were talking about this yesterday, right? That it's amazing that all of these errors happen and we just accept it. We wouldn't get onto planes if we knew that 2 of them would fall out of the sky every single day. But they're not visible, which is part of the problem. And just last metric around this, which is that the Joint Commission puts out their reports on what causes the errors that are reported to them. These are the top 5 errors in their 2022 report. And time again, they show that communication breakdowns are the leading contributor to all types of errors. And when you look at the 5 errors there, they're not things that you would readily say, oh, this patient fell because of a communication failure. But at the end of the day, all of these things are being affected by our inability to work together as a team. And what JACO says, or the way they kind of break down communication, is it's a failure of teams to have a shared mental model of what needs to get done for a patient, to communicate with each other, and to follow the standards. And what I find most disheartening about that figure is that it hasn't changed since the 1990s. It's the same thing. That's from before EHRs were implemented. So we clearly need to actually do better. So what is communication? My guess is that many of you are thinking of things like this, like talking and gesturing and sending secure messages to each other. All of these are forms of real-time communication. But in clinical medicine, we also have handoffs. We have discharge rounds. We have everyday rounds. These are all forms of how teams communicate together. But I would argue also that documenting in the chart, entering a vital sign, placing an order, these things are also all forms of communication and the way we should think about couching how we improve these metrics. And I think it's the part that we're usually missing because we're so focused on how do we talk to each other. When you look at the definition of communication, it's the exchange of information between 2 people. As I mentioned, there's real time and there's asynchronous, like placing an order in the chart to say, please, send someone to do a portable x-ray of my patient. That's me communicating with the radiology tech through a computer. Collaboration is another word that we use often, as is coordination. I think whenever we hear the word communication in medicine, we should be thinking of all 3 of these things. Collaboration, how we work with someone else to accomplish a goal. That pretty much sums up taking care of patients, and coordinating all of the different people involved. So really, it's all about how we work together. Okay, spent a fair amount of time setting up the problem. Now I'll talk about my experiences working in them. As I mentioned, my goal has always been and continues to be, how do I make it easy to do the right thing for clinicians, for patients? So how do I make it easy for clinicians to do the right thing for patients? How do we reduce friction in our day so that we actually choose the right path for patients? We talk about workarounds a lot of times. In my mind, a workaround is something that we do because the process or the technology was simply not designed well enough for me to accomplish the goal that I needed to do for patient care. So it's really us being resourceful to be able to take care of patients despite not being given the right tools. So there's a lot of ways to address teamwork and communication and burnout. The 2 that I focused on over the last 15 years has been clinical data. So how do we get the right information to the right person in the right format at the right time so that we can facilitate decision-making? And how do we work together as a team, keeping the patient in the center? And when I say team, I very specifically mean all disciplines, all specialties, all care settings. Too often, our systems have us working in silos, but really, we're all on the same team taking care of a patient. So if we start with the first, keeping track of data that we need to access throughout the day or reference throughout the day, do these papers look familiar to anybody, or these types of papers? So the clinicians in the room. Okay, I'm talking to anesthesiologists who often have wows in front of them, so maybe not as often in the unit. But this is really the gold standard. I don't use that word lightly, but the gold standard of what people use, right? We print reports, we handwrite things, we use whiteboards. This is the main way that we keep track of vitals, labs, meds throughout the day when we're not sitting at a computer. Or what did the patient tell me this morning when I walked into the room? What was that exam finding that I don't want to forget when I write my note later? We do have some mobile EHR apps. I'm willing to bet that hardly anybody is able to replace papers fully in their workflow based on currently designed EHR applications. So we measured how often we were printing papers at Penn. It averaged out to be 23 pages per patient per day across the health system. This was just for rounding reports, nursing shift reports, and sign-out reports. That's over 14 million a year. And for anyone who's interested, it's about 200 trees a year. That is an incredible amount of fragmentation of information and teamwork that we don't have access to because it's stuck in our pockets. Paper is not inherently bad, but it is static, and care delivery is most certainly not static. There is data showing that printed documents are out of date within 3 hours of being printed. This is from 8 years ago. I am sure that number is less now, given how quickly we are constantly ordering tests. We measured how old the papers were that people were carrying around. On average, they were 9 to 12 hours old. So information is quickly outdated. We carry it around forever, and then we're making decisions off of it. No wonder we're making mistakes. And finally, paper is not collaborative. By definition, people think, oh, here's a new piece of technology. I have to log in. It's a different system. Paper is a system. It's something you have to find. It's something you have to keep track of. And fundamentally, anything you write on a piece of paper, you have to double document to be able to share with someone else, or you have to say verbally to be able to share that with someone else, because no one can see what you've written. And in case you're thinking, oh, well, the EHR has everything I need, I should be able to easily find that. We don't need these papers at all. We looked at how much information is in EHRs. This paper is just looking at words in charts, not even all of the other data points. We looked at every note at our health system for 6 years. It was over 100 million notes, 190 billion characters. For reference, all of English Wikipedia in all time, when we wrote this paper, was 24 billion characters. So one health system in 1 year generates more text than in all of Wikipedia in all time, which is staggering. The median number of words in a chart was a little over 4,000 words, which is about 1/6 of Hamlet, which is Shakespeare's longest written work. So if I have 12 patients, that means I'm responsible for the amount of words in not just one, but 2 copies of Hamlet every single day. And we found that 54% of all the text was directly duplicated from a prior note, but you don't know which 54%. And now you need to go quickly find what you need to do to be able to take care of patients. So clearly not sustainable. We're doing a follow-up study, so this is not finished yet, but I wanted to share some of the data, looking at how many other data points are in the chart that we're having to think about. So vitals, labs, orders, problem lists, notes, radiology imaging studies. What it doesn't include is the media tab, the Care Everywhere tab, so a lot of things. But essentially, at the start of encounters, averaged across all encounters, the median number of data points is 1,000. And if you look at that red line, that's the 90th percentile, which I would argue represents most of the people that you're seeing when you're taking care of patients in the unit. And that is 7,000 data points at the start of an encounter. And it grows, obviously, every single day. We generate, on average, about 120 new data points per patient per day. So oftentimes when I show this to people, they say, oh, well, AI is going to fix this. It's going to take care of everything. AI will definitely help us find information. It's not going to fix the problem. We really have to attack it from both ends. And probably one of the take-home points here is we can't be expected to be able to know everything in a chart. Just because it's there doesn't mean that we've seen it. And the second is that not everything should go into a chart. We don't have to have every single thing that we ever say or write about a patient end up in the chart, because it just makes it really hard to find the relevant information when we need to. So that's the data. Looking at teamwork and the challenges that we face around keeping everyone on the same page. There's a quote by Maslow who said that if the only tool you have in your toolbox is a hammer, then you start to see every problem as a nail. I think that's really effective analogy for medicine, because the main tool that we have to be able to communicate and work together as a team when we're not physically in the same space is a message. Whether it's an in-basket message, a secure message, an email message. But I want you to please think about every message as an alert, because it means you have to stop what you're doing, you have to go look at it. If it's a secure message, you have to actually unlock your phone to look at it. You can't just, triage it based on your notification feeds. It is simply too much, and this digital communication overload makes it really hard for us to be able to do our work together. And it's not the right tool for the right job. Not everything that we need to do and communicate or collaborate as a team needs to be a text message. This is data also from a paper we're working on, looking at how many text messages people are receiving and sending on clinical teams. So these are not ICU teams. That data is still being crunched. I'm sorry, I don't have it. But on the left side, you see general medicine teams. On the right side, you see specialty medicine teams. Each column is a different frontline provider by role. And essentially what we found is that every frontline clinician, intern, and resident is getting interrupted by a message they receive or have to send every 2.2 to to 4 minutes all day, every day. That's like someone sitting there every 2 minutes and tapping you on the shoulder and be like, hey, I need you to stop what you're doing and look at what I'm doing and see what I told you. And oh, by the way, it's not relevant to what you're doing now. It's relevant for 4 days from now, but that's okay. I need you to stop and do it now. Part of why I started doing this work was because I was in the hospital with my mom, who's fine, but in the process of the hospitalist talking to her, he looked at his watch like 3 times, talking to her about her SBO. And I was like, oh, I guess he's, has a lot of things going on. And then I realized it was secure messages. And that happens, I bet, to all of us. When was the last time you could have a full conversation or hear a presentation from a trainee and not get interrupted or have them get interrupted every couple of minutes? And we know that context switching causes errors. For nurses, the number is every 6 minutes on medicine and 9.7 minutes across the board. So interruptions are really causing a problem. And what's funny is we have this illusion that we're communicating. We're sending all of these messages. We must be on the same page. But it's an illusion. We're not communicating effectively. So I want to show just an example of how that pans out in a real setting. So this is a real example. I'm sure all of you have experienced this before. So imagine a patient admitted with pneumonia, Mrs. Smith. Straightforward admission. We expect her to go home on day 4. So her nurse comes in the morning and she's like, oh, am I going to be able to go home today? And the nurse says, I'm not sure. You look a little short of breath. We should, let me check with the team. You might need oxygen. So what does the nurse do? She writes that on her paper that she printed that morning or maybe on her scrub pants. And because nobody can see that, she then has to go text the team who's rounding with another patient and gets interrupted. And they say, we will come address it with her when we come round on her. They come in a couple hours later. Poor Miss Smith has to ask again, can I go home today? They say, yes, don't worry. And she's like, I don't understand. The nurse just said I need oxygen. Now you're saying I can go home. And they're like, oh, no, don't worry. Yeah, it's fine. We'll send you home, but with oxygen to bridge you for a couple of days. So now the team writes that on their sheet of paper. This is a real one that I took a picture of. And they say, we need to set up oxygen for her to go home. They go to the EHR to start the process because discharging is complicated, takes a lot of steps. They wanted to do it on time. But before they could get that message to social work, they get called into an emergency with another patient. So now what they've written on their paper is trapped in their pocket. They've become a single point of failure. Everyone else starts down this long road of processes to try to get Ms. Smith home on time because there's immense pressure to do so. And obviously we want to provide good care. And that message about setting up oxygen never makes it to the social worker. And despite all of those messages that you saw flying back and forth, she ended up not going home that day and had to go that next day because oxygen wasn't set up in time. The reality is that these kinds of communication breakdowns, which are silly, they should be completely avoidable, actually impact almost half of all admissions in the United States. And if you saw with that one patient and 3 providers, there were dozens of messages flying back and forth. But the reality is that that nurse has other patients, the doctor has other patients, a social worker has other patients that they're getting texted about. Those patients have other providers that are getting texted. It's really this horrible cacophony of our phones going off. And I think many of us feel like this within a couple hours into the day because it just doesn't make sense. And I think it's a perfect illustration of this quote, which is that there is a serious cost to bad design. And whether it's bad design of processes or bad design of technology, it has real impact. And if you penny pinch up front about it, then it's going to impact the outcomes that you want to get to. So I did say you could have your cake and eat it too. So let's show some examples of how we can actually take this craziness and make it better. So I mentioned a lot of all of my work has focused on technology and how to support the processes. You really can't untwine them. So it really is about designing better processes and technology together. My initial charge, it was to get rid of this piece of paper from my CMIO. And I was like, you are crazy. That is not possible. I had built all the prior handoff systems for our organization. That paper was one of them. And I was like, there's no way we can do that without paper. And I got some good advice. But really what I had to learn was we have to completely throw out our assumptions of what is and isn't possible and how we've always done things. And to think not just outside the box, but think outside the EHR. Almost always we start with, okay, what can we do in our system? But it's not always, one system can't do everything. We should absolutely evaluate it, but we shouldn't stop there. I also learned that we have to think outside of medicine. And from a technology perspective, our industry is like 20 years behind most other industries for lots of reasons that we won't go into during this talk. But we can learn a lot from how other industries have iterated on many of the same problems. So if we think about the problem that I was focusing on was access to the right data at the right time and teamwork. So the way other industries do this is project management software. How many people have heard of any of the applications that are on this screen? Great. And then if you're, okay, I was trying to see how many people are clinicians who've heard of these softwares. Oh, that's great, so a lot. Usually when I talk to clinicians, they have never heard of project management. They don't know what any of these platforms are, but it is a well-established thing that we use in every other industry, from aviation to construction to party planning, because we know that if you're on the same page in a shared workspace, then you'll be able to keep track of what gets done and accomplish your goals more quickly. Most of these tools have these two components: access to the data that you need to drive your project goals, and clear definition of what needs to get done for this project, who's doing those things, what's the timeline, what's the current status, what needs to happen next. If you apply that to patient care, it's the same thing. The data is vitals, labs, meds, or what was the patient's exam, and the plan is, the treatment plan is the second part of this. What needs to get done? What are their problems? What are the things I need to know quickly? Who's doing what task? What's the status of it? And where do we go next with it? So we worked to take all of these fragmented things that we use for communication and collaboration and coordination and put them all into one coordinated space that everyone could access, everyone could work on together. You can think of it as a digital huddle. I haven't figured out a good name for it, but we'll call it a digital huddle or a team collaboration platform. But it's a patient-centric space for people to be on the same page of what needs to get done. Drastically reduces the amount of messaging you have to send, replaces the papers, but importantly, it keeps us organized and making less mistakes. So I mentioned constant iteration. The screenshots I'm going to show you are very different from what it looked like when we first implemented it, because we've constantly been changing. But at a high level, it does three main things, and I think these are components you can incorporate into other systems, but this is what we found were most necessary. So the first is interdisciplinary tasking. We have work lists in the EHR with nursing orders, but there is all sorts of tasking that's happening on papers and in emails and in sticky notes and in texting, which really should be in a shared work list or a shared task list about a patient. Has to be easy to access, has to be easy to change, has to be customizable. It can't be something that you have to define in a flow sheet in an EHR that, never changes, because that's not the way we provide care. It needs to be able to be dated and timed, set reminders for certain tasks, assign it to a person, assign it to a role. Honestly, these are things that feel silly to even talk about because they're in pretty much every other application we use in life, just not in medicine. But that concept works in medicine. The second is data visualization. So many of our tasks are directly driven by clinical data. So we really, and this was a big part of what I realized we needed to be able to do to get rid of those papers, is we needed real-time access to the data that people were spending an hour every morning writing on their papers, vitals, labs, meds, a quick view of what you needed to see about a patient, whether we're in the unit or on a floor, and have the ability to easily drill down on the data when you needed to get more details. And then finally, diagnosis capture. So this is something that we actually built in later, but we realized that there's all of this valuable information that we were writing on paper and in email and in text that really should end up in the EHR, should be coded into diagnoses. So with human factors and workflow at the forefront of everything that we built, we made it really easy to say, okay, if you're writing a task around, following up on someone's edema, you can easily attach the problem of lower extremity edema to that and bring that into your chart for better outcomes metrics, more complete outcome metrics, and billing. So I've shown a lot of screens of a phone, but we had to build this really for every device and to integrate it into the EHR. By necessity, I think any tool that you build outside of the EHR has to be able to integrate to any EHR. We've talked about FHIR at this conference. FHIR was not the thing when we first built this, so we have retrofitted to be able to work with FHIR. But also, the vast majority of organizations in this country are not yet FHIR enabled. They're getting there. It's at least finally accepted that it needs to happen. They're not anywhere close. So you need to also be able to use regular HL7, use ADTs, use CCDAs, all of these other formats of data, and to be able to bring data from multiple different data sources, because many organizations don't have one EHR. They have multiple. We had 10 when we started this project. We integrated this, not in the beginning, but we then integrated it into the EHR from a workflow perspective. This probably drove nursing usage the most because it was a lot easier for them to get to. And I think, for good adoption of technology, this is really important. It has to be in the workflow where you are at the time. So if you're at a computer, it needs to be accessible within your EHR. If you're not at your computer, you need to be able to pull it up quickly without having to go into your EHR to get it. So you need to be able to manage the best of both worlds there. And these are just showing that you can access all of that data visualization right from within the chart as well as the to-do list. The best is most people don't even realize this is another application. They just think it's a native part of Epic, which means we've done a good job of making it feel normal. So what does this look like, this process, this reimagined teamwork when you have the right tools for the workflow? So Ms. Smith, on day 4, when her nurse comes in and she says, "Can I go home today?" The nurse says, "I'm not sure, let me check with the team, but I can see in our discharge view of our list that we're nearing discharge and we're gonna try to wean you off oxygen." Now, instead of writing it on paper and texting, she just writes it once in a shared space and says, "Hey, Ms. Smith wants to go home," tags the attending, "Is that okay? She's still a little short of breath." At the same time, tags the social worker to say, "We're gonna need to set up oxygen for this patient." Now, when the team comes in, they have not been interrupted while talking to another patient, and they walk in the door on the same page. Ms. Smith isn't having to steward her own care. The doctors come in and say, "We see you're talking to the nurse about going home today. You're a little short of breath. We're going to send you home on oxygen to bridge the next couple of days." Instead of writing it on paper, they check this off and say, "Yes, she can go home." They add a task for the social worker to set up oxygen. Now, when they get called into that emergency, they're no longer a failure point. Everyone can see what needs to get done. The social worker sets up the oxygen, sets up the shuttle, and Ms. Smith ends up going home on time, on the same day, and without any text messages flying back and forth. I think I failed to say this before. Messaging is not bad. Messaging is absolutely important. We need it for many things, but there are a lot of things we don't need to be using it for, and that's part of the idea here is using the right tool for the right process and the right job. One of the areas we're really excited to take this next is what can we learn from the actions that teams are taking, as Mike talked about yesterday, which can be really hard, right? Like the judgment and the actions. The EHR is only one part of our workflow. It doesn't capture what we're doing on email and text and fax and whiteboards and all these other places. But if you have it in a consolidated space, then you can actually start to learn what are the types of behaviors that teams do that work well? What are the types of behaviors that don't work and end up in a bad outcome? What does how teams are working together tell us about the status of the patient? Maybe it's the next vital sign. So that is an exciting place that we're taking this. And then I wanted to share, I know my talk is not about health equity, but it's something I'm very passionate about, and we've had some great talks about it. And I really wanted to use this as an example of how when you have technology that can be agile, you can use it to address problems. It's a tool. So we did a study 15 years ago looking at whether a computerized nudge could change people's behavior in what they would write in their clinical documentation. So I won't bore you the details on it, but the answer was yes. You can nudge people in one system and it will affect what they write in other systems. And in fact, it has a bleed over effect on the people around them as well. So it's like a very effective means of getting people to start doing the right practices around documentation. So we applied that to the use of stigmatizing language. There's a lot of data that shows that the language we use can perpetuate bias for patients, even if that was not your intent. Your reader might have implicit biases. So we built these nudges in our application so that and we started with words recommended by the CDC and APA. I just implemented this a couple months ago, so I don't have usage data yet, but I have gotten qualitative feedback from people that they really like it and that it's been easy to use. But essentially, as in this example, if you write poor historian, then it'll nudge you and say, hey, that word can perpetuate patient blaming bias. Just hit enter and it'll replace it for you with is having a difficult time recalling their history. And there is a place to get more information. You can click to understand why am I getting this annoying alert. You can opt out of it if you want. But our goal with this is to help make it easy to do the right thing, to improve patient care without adding work to someone's day and in fact making it better. And what I've already heard from the people using it is that they're already starting to use these words less because they remember now after getting the nudge a couple times. So I'll go through this part quickly. I'm happy to talk more. And my watch is dead, so I don't actually know what time it is. Oh, okay, I have my timer, thank you. So the results of how our implementation went are in the ACI journal. I'll go over them quickly. These are focused on our initial implementation and deployment at Penn, and then I have some additional data since then. But essentially, my simplified version of implementation science is if you incentivize people with a carrot instead of a stick, you actually will have much better outcomes. Now, maybe I don't like a carrot and maybe I want chocolate instead, which is probably the case, but give people the right thing that actually helps them with the goal that they're already trying to accomplish, and they will want to use it. Obviously, there's a lot more that goes around how you implement effectively, but really I felt like that was the take-home point for us, was at the end of the day, people realized this was saving them time. It was just making their day easier, so they wanted to adopt it. On the bottom, you see the unique users per week of the application broken down by role for the first 6 years. I don't have actually the first 8 months of it because we didn't collect that data, but you can see that we had an initial deployment with data visualization, added in the tasking, and then have had really steady penetration. That one blip is when we went live with Epic, so there was a lot of change activity around that time, but really interdisciplinary. It was really exciting for me to see how much nursing uses this. That was unique users per week. This graph is showing you how many times, who's logging in the most. So the most logins are from trainees and from advanced practitioners, then nurses. But what I love is without any kind of actual secure messaging in this application, we are effectively helping teams be on the same page. The most common thing you'll hear a nurse say is, I don't have to constantly text the team to find out what's happening because I can actually see what's on their list. And I know that, oh yeah, they are planning to come and talk to the patient in a couple of hours. In terms of quantity of information, so we see on average that people are making edits to tasks and information anywhere from 35 to, actually this number should be around 60 times per patient per day. That's cumulative across everybody interacting with that patient. So it's a lot of information that would have otherwise been fragmented across 23 pages per patient per day and not visible. This is looking at how many actions happen every week. It's a little over 2 million. You can see the majority of activity is actually within the EHR. So when we're in the EHR, that's how people are interacting with it the most. And then when they're not, they're using their mobile device. We observed people on rounds to see how this was changing behavior. And essentially what we saw was that teams not using the application in gray versus teams using the application in purple were 50% more likely to access real-time data during rounds instead of saying, well, if the hemoglobin comes back, we'll do X. They actually looked it up in real time. And then, but they spent 25% less time logging into devices because it's just faster to get into, so easier access to data. We implemented with half of the medicine teams first to then be able to ask them what they thought about it, and saw that across the board, people felt like it was safer, they were more satisfied with it, they were more likely to recommend it to somebody. And from an acceptability standpoint, is easy to adopt. More than 70% of people said it was easy to learn within 3 days. They felt comfortable. That was with a video and train the trainer model. 3/4 of people said it has actually prevented errors in their care, which was our original goal. And 4/5 of people have said it saves them time. Usually the average is people say they save about an hour every day. And then CLASS, if you guys know about CLASS, and they have the ARCH Collaborative, which is really focused on EHR experience. They recently did their EHR experience survey at Penn, and basically found that people who use our application in conjunction with the EHR have a much better experience with their EHR. They feel like it helps them accomplish their tasks. They feel like they're able to collaborate about patients better. So really, it's optimizing the investment we've already made in our systems. So at the end of the day, when technology is designed well, when it actually helps us do our work, we will not just use it, but we will actually love it. I think too often people say clinicians hate computers. It's absolutely not true. We just hate really badly designed technology. When it's designed well, we absolutely love it. And it should work for us, not the other way around. And I just want to end with this again, which is please don't accept the status quo. I think one elephant in the room is we don't get to make the purchasing decisions usually about the technology. That's a whole nother thing I could talk about for an hour. It's one of the biggest challenges, but we hold a lot of power in our organizations. We're providing the care. I think that we need to leverage that more and say, this is not okay. We need to be able to have the right tools, to do the right job to provide the best care for patients. Thanks.
Thank you. That was great. Thanks for sharing all your hard work. We have a few minutes for questions and comments from the audience before the next panel. There's microphones as yesterday, and please come on up.
Testing. Good morning.
Good morning.
Enjoyed your talk very much. Thank you. First question is, are your slides going to be available online or as a handout somewhere?
I'm sure we can make them available. I don't know. Are you doing that with slides?
I think we will have the video of the whole conference available is the plan.
Okay,
Yes.
great.
Mike Eden's giving me a thumbs up. Yeah.
Because you talked about communications, and that's something that I'm working on hard through the patient safety movement, in particular handoff communications. And as you know, the Joint Commission has identified communication failures as the leading cause of medical errors resulting in patient harm, and you covered that nicely. One of the problems with communications, especially handoffs, is they take place in stressful environments. Like for us anesthesiologists, you're literally running alongside a gurney that's going from the ER to the OR and a trauma patient, and you got to watch where you're going, so you can't be looking at a piece of paper. And you mentioned the importance of bringing in new modern technology and getting rid of the paper. That's something I would like to see, but I haven't figured out exactly how to do it. Have you looked into starting with your iPhone, which everybody has, the use of technology, not only in getting you through the checklist, I'm a big fan of checklists, but also helping you avoid the distractions that often cause communication breakdowns. And that's something that that I stress is it's often distractors, things that are not even important, but they break your attention string. Right. And cause failures to communicate. So anyway, sorry, that's a rambling question, but what do you think?
No, it's great. My work actually started in doing this for handoffs. As you probably noticed, I barely say the word handoff because I think it anchors us into thinking of it as one thing, when really it's about how do we effectively communicate as a team, regardless of whether it's a shift change or care change. Fundamentally, I think if we are reducing a lot of the messaging that is reducing interruptions, but I will admit that I'm not an anesthesiologist, so I'm not an expert in the perioperative handoffs like Megan and many others. I do think that there are ways we can use technology to provide quiet spaces, at least when it comes to interruptions there. But I'd be happy to talk more and think more about what are the other kind of distractions that are happening in the perioperative space that we could attack.
Great. I would love to collaborate with you.
Okay,
my name is Steve Barker.
Nice to meet you,
Let's
Steve.
talk.
Thanks.
Megan, over there.
Subha, that was phenomenal. Thank you. One of the areas of interest yesterday was thinking about monitoring at home, and I'm thinking about transitions from the acute care setting into home. And when I think about information voids, I think about home health care providers. My dad was discharged from the hospital, and his home nurse was didn't know what was going on. And I see opportunities for what you've built with care outside the hospitals. I'm wondering if you can talk about the extent to which you've thought about that and applications of Caroline or similar technologies to bridging those transitions across care settings.
Yes, thank you for asking that question. I promise I didn't plant it, but it's perfect because I didn't include those slides. So as a hospitalist, I really only came at this from the inpatient perspective, but in the last few years, particularly starting with geriatricians, have had people bring it into post-acute care, in home care, and in value-based care. And it's really been so educational for me as a clinician that the challenges we have on the inpatient setting around how we work as a team are the exact same challenges in the outpatient setting. I think it's even harder because we're not in the same space. We're not even employed by the same organization. So we have actually had people use it in nursing homes, in skilled nursing facilities, in home care. And part of what's, I think, an opportunity is that it can be EHR agnostic. It can span across any different type of technology. So in home care settings, if you have a contracting nursing group and a contracting therapy group and a contracting, something else, or a community health worker that's working with somebody, everyone can have access and collaborate together. So absolutely, bridging the gaps across all those care settings is something that we're doing, and I'm very excited about. Thanks, Megan.
Over here.
Sure. Yep. Phenomenal talk. It was very interesting. Just tying together a few threads of communication, technology, and artificial intelligence that we've discussed throughout this conference. One emerging technology that I've been interested in learning about is ambient clinical intelligence, which is this notion of voice-activated recording devices within, patient, patient exam rooms or operating rooms or all throughout the hospital, and then enabling clinicians to have a seamless conversation with other clinicians or patients. And then you have a documentation of a automated, generated note, using large language models and other kind of AI-enabled technologies. And I was wondering if your team has thought about that and how that could enable some opportunities, and also what could go wrong with that and what we need to think about to mitigate unintended consequences of ambient clinical intelligence.
Yeah, well, I think we can talk about that for a long time. Have absolutely thought about it. Most of the ambient technologies are in an outpatient setting because of all of the challenges of the inpatient setting, which is that you don't have this confined start and end time for inpatient encounters, right? I might see someone 5 different times before I finally write my note and consolidate all of that information. I think that's probably one of the biggest barriers. That, and in most inpatient settings, it's not just you and one patient, there's many other people. So you'd have to do, I think, a lot of work to make sure you're picking up the right conversation and not mixing things. But there's a lot of potential, I think, even on the outpatient setting of how you could kind of bring shared tasking in with ambient scribing around the identification of follow-ups. Because normally what we do is we write our follow-ups, which are action items, into notes, and then you have to separately message someone about, hey, this is what I wrote, we need to make sure it gets done, and then you have to make sure it got done. But if you can use technology to pre-populate a lot of that stuff automatically from those things. The inpatient setting is absolutely something I'm looking into, just not there yet, but happy to talk more about it.
Okay, we'll take one more question from the audience.
Hi, Chase Sims from Mayo Clinic. Thank you for your talk. It's been a fantastic conference. It's amazing how hard people work to fight to stay in the status quo, and they don't realize how much mental energy they're using. We're all going to need a lot of carrots, I think, in the future, especially as implementation science comes more and more to the forefront. In your opinion, I know you could probably do a separate talk on it, but when you were implementing this, overcoming kind of the burnout, as you mentioned, that comes with EHRs, do a couple of things come to mind that were really successful for you guys and how you navigated that?
Yeah, that's a good question. I think one of the things is something Megan said yesterday, which is that it starts with listening and understanding what a group's challenges are. I think everyone thinks that their challenges are unique, but I think you start to see patterns that are the same, but they need to feel heard. So starting with that is really important. When it comes to, and then you kind of have to do this translation of what you're telling me your challenges are, what this technology can and can't do. A lot of my role has been saying, okay, this thing that you're asking for and that you need to solve for, this technology won't be able to address and we should build for it. Or it can, it's just a different framework of how to think about doing what you need to do and what you've always done. From a perspective of how you implement, one of the big things that we did, which I think was really successful, was started with what was the easiest thing for people to adopt before doing the hard thing of changing your workflow. So we started with, and it was the first part of that user graph, was we started with just data visualization. We said, don't change what you're doing. Here is a nice to have rounding tool that you can use if you want to. Literally sent one email to the entire health system. You know how effective those are, and it spread organically from that. Because people saw it, they're like, oh, wait, I want to use that. I want to use that, show me what you're using. And once we then had people's trust, someone mentioned trust yesterday about how it's really important. We have to trust that the technology is going to be reliable. It's going to do what we expect it to do. It's not going to leave us hanging when we're running to a code. So once we had that trust with people that it was something that they could rely on for their patient care, then we started adding in the workflow change. So I think as much as possible, if you can start with the smaller part of change and then bring in the bigger part, it's more effective. Thank you, everybody.
Okay, thank you so much. All right, we got a great start this morning. We're going to go on to the panel that's going to bring some of this together, and I'm excited to hear what our next speaker, Dr. Mike Scott, is going to share with us, because that path that we talked about from wearables to AI to back to the bedside is something that Mike has been in the middle of developing for a long time. So Mike is a professor in the Department of Anesthesiology and Critical Care Medicine at the Perelman School of Medicine at the University of Pennsylvania. He's the Division Chief of Critical Care, and he's the Medical Director for the Tele ICU Pen Alert. He's one of the first clinicians to have developed ERAS, Enhanced Recovery After Surgery, in 2001, which has gone on to have an enormous impact on surgical outcomes and is now a standard of care. He came to the U.S. in 2016 and contributed to the AHRQ ERAS guidelines for the American College of Surgeons. He has a keen research interest in surgical outcomes research. He's been an investigator and chief investigator for multiple studies in analgesia, hemodynamic monitoring, fluid therapy, and the stress response for surgery within an ERAS protocol. His current projects include creating dashboards to improve data integration in the electronic health record and integrating live physiologic waveforms to individualize treatment for patients. Please join me in welcoming Mike.
Thanks, sir. I'm mic'd up, so that'll be fine. Thank you very much, Jeff. Well, thank you for that kind introduction. It's a real pleasure and honor to be here. So my task is to tell you about Tele ICU now and the future. But actually, this has been an interesting journey for me, because when I went to Penn, I hadn't really done Tele ICU before. And this has been a journey developed through COVID. But I think what we've ended up is with a platform that is backbones for every single health system for the future. These are my disclosures, but the only important thing is I have no relationship with Epic, because a lot of this talk is going to be based on the Epic Tele ICU platform that we've built at Penn. I'm going to talk through what we all know about a traditional Tele ICU and its functionality, look at how we can build high reliability into the platform. And I think the real difference of what I'm going to show you is we've always had monitoring and our EMR in parallel. And this is the first time the whole thing's ever been integrated in a way that you've got structured governance and two-way actioning within the EMR. And as I say, I think I'll point out in the future that this is the basis can be used not just in the ICU, but across the whole of the health system. So for those that don't know, Penn Medicine, it's a big academic health system based in Philadelphia. We've got 6 main hospitals. One of the terms I'll be using is Penn ELA. That's purely what we call our Tele ICU program. It's actually been around for about 25 years and at Penn, and it's a 24/7 bedside support service. So it's an addition to the bedside provider. It's not replacing the bedside provider. But since I've been there, we've grown it from really quite a very small system to basically the biggest academic Tele ICU platform in the country. We've got 450 ICU beds, and we have many other monitored beds because we're now branching out into high-level care. And we've also got portable platforms as well for emergencies and small community hospitals and things. So these are the 7 main hospitals we deal with. So they're big hospitals. I mean, Lancaster General is a standalone hospital in itself with its own cardiac department, as is Chester County. And then we've got the downtown hospitals, and we're also in New Jersey at Princeton. The whole basis of the staffing is we have 4 RNs 24/7. So they have about 100 patients each, which is a lot for an ICU, but you'll see with the platform we've got, they're highly efficient. And they're also a filtering mechanism, as well as the fact that they've done ICU for at least 7 years, all of them, so that they recognize problems. We've introduced a 24/7 APP model, and we've also got 24/7 respiratory therapy, which I'll talk about, which is the first ever in the world. That came through COVID. And then we have nighttime physician support. We don't need that during the day because the teams are on the ground, and as well as a telehealth coordinator. And really, this is what triggered it all. This was Megan's and my life for a year or so, wasn't it, Megan? COVID, it completely disrupted technology. Everyone was willing to grasp new things. HIPAA was sort of parked, wasn't it, for a while, and everyone could use any platform they wanted to deliver patient care. And the opportunity came really because I was out. To give you an idea of what we did. I mean, we even were called on Christmas Eve to support one of the vent facilities in Philadelphia because the whole system had run out of ICU beds, and there were 60 patients with COVID. And we went in with iPad cameras and supported their respiratory therapists. So we effectively stood up a tele-ICU for 60 beds within a few hours and had it centrally linked back to our downtown Rittenhouse, where our core is, where all those people were. But the real opportunity came when we were asked to partner with Epic, because the opportunity was to build our platform within the EMR. And so that's what I'm going to go through. And as I say, this is the first time that everything's been fully integrated. And I'm going to start where we finished because I think it's easier, and then how did we get there? So this is one of my APPs. This is the average sort of dashboard that they'll look at. So if you think we've got unit data, so the top left is a list of patients that you'll be looking after. So the nurses have more, and then obviously higher risk patients get then transferred to an APP or an MD. And you can see, so it's like a watch list with basically cycling, SOFA scores, and then the best practice alarms. So you can see, and then a patient goes to the top, on the top left, if they fire red. So the whole hospital system is live, and every patient that has a BPA that fires, which is red or orange, will go to the top of the list and get looked at next. The second screen on the top right is a physiological data set for the patient. The reason that is in black is we've actually built this whole thing in something called Epic Hyperspace on Warp Drive. Now, before you all think I'm a Trekkie, I did enjoy that when I was a kid. But that's just the term that Epic used for basically running almost a parallel EMR, but it doesn't have the functionality. It's purely a graphical interface. And that's why I took the advantage of it, because those of you that know me know that I was a photographer before I went into medicine. I'm a firm believer of graphical interfaces. And Careline, which just got presented by Subha, that's a fantastic graphical interface. We use that a lot at Penn. So I've effectively done a little bit of what she's done, but into the EMR in the tele-ICU. And the whole idea is to stop the clicks and to just see the data and to visualize the delta. So that's really what this is about. So I always remember this, the craziest thing that we had back in the UK is they started to say that we needed to have all anesthesia syringe labels the same color so that you read the label. And I kept saying, well, we're very visual orientated animals. We're color based. So red is good for muscle relaxants because it kills people. And you're color based. So you shouldn't be reading. So that's basically how we've designed this interface, so that everything is just a delta and a color. You don't actually need to know the value. You know that something bad is happening to the patient. And then finally, the bottom left, you've got the classic interface that we've got. That's where the camera system goes in. And then we've got our own other clever dashboards on the right, which I'll show you. This is a game changer. It's a new type of camera. We've partnered with them. And it's so high powered that you can basically see what's written on someone's iPhone in the room. It's two-way, it's Zoom, it's controlled by the downtown tele-ICU people. But the thing is it gives you situational awareness and two-way communication. So our picture goes up on a board so the provider can see us and we can see them. So it's immediately like FaceTiming. But the other great thing we've done with this is stopped working, by the way, sorry, is this can be used to get any single person into the room, anywhere in the world, within seconds. So basically, if you press the alert button on the wall, which every room has, and you say, I want Dr. Mike Scott now, I will get a immediately URL. I'll go on my phone, I press the link, basically up there. That's what comes up on my phone. I accept it, and then I am in the room. You can see me top right there, and then I've got situational awareness. I can control the camera, and we can bring other people in. So I'll say, oh, right, we need a cardiac surgeon in on the call, get them in on. So immediately you've got a path to high-level decision-making, which is one of the failures of delivering high quality and high reliability. So this has been an amazing addition to the system rather than just normal zoom cameras. You're all aware that most tele-ICUs are all about reactive. So you've got immediate threat to life, trending threat to life. I don't really need to tell you what these issues are in the room here, but we've worked out that 80% of the opportunity is basically at weekends and at nights, and it's no coincidence that's when we've got lower bedside staffing. It's inevitable, isn't it? And also we can talk about monitoring again, can't we there? But that's another can of worms that we've already discussed. So we support the bedside provider. We can watch the patient for them as well. We can get all the teams in. We can fire a massive transfusion trigger. We can record video, so it's a learning opportunity. And so this happens a lot, but mainly, nights and weekends. But the real service that we've built up is this proactive service, and it's all about quality bundles, and it's everything from respiratory to sepsis to ICU bundle, and it's become basically a platform for system-wide quality improvement. And it's a continuous opportunity. It's harder, isn't it, with all these quality improvement things to show cause and effect. But if you do the whole bundle of elements, just like when you've got enhanced recovery, it's hard to actually say it's one thing that's doing it. We know that some things are probably a bit more impactful, aren't they, like fluids and blood pressure. But on the whole, you need the whole thing. And this reduces complications and secondary problems downstream as well. This is what I work on when I was in Virginia as sort of perioperative quality lead. How do we fix the space? And these are normally the points of failure. I'm going to start with the bottom one first, really, which is what we call a safe environment, which we've introduced at Penn now. A safe environment, not clinically safe for patients. It's where everyone is free to ask for help without feeling that they're weak or looked on as not knowing their things. So it might be just a nurse. We had one the other day. A nurse said, I don't understand this. I've had to pull 20 ampoules of this drug to give this. And she was sensible enough, she called because the dose had been entered wrongly. And she was sensible enough to think, oh, actually, this isn't right, isn't it? 1 ampoule's normally enough. Why am I pulling 20? So it's at 3 a.m. in the morning, and rather than giving it, she didn't know who to call. She didn't want to challenge the bedside provider, so she called Penela, and we said, yes, wrong dose, you're right. So it was a good save. And it's these little catches like that that really help the health system. It's not just about going in there when patients are dying. So we created a safe environment, so I don't safety net anyone or anything. I just pick up the phone if there's a problem. And then you've got the things like there's failure to follow best practice. So that's, as you can see, that's more proactive management. There's failure to recognize a problem and failure to escalate it appropriately are 2 points of failure. And then lack of governance in any of those above. So I'll show you how we fix this with the platform. And then could you fix this? Because it sort of slides behind for some reason. When you look at costs impact to your health system and using this as a big quality improvement tool, our average cost at Penn is about $17,000 as our median cost. So the actual, once you've got your tele-ICU in place, it's actually not that expensive when you look at the cost of running it every year compared to the number of complications that you save. And we're all aiming, aren't we, in the C-suite for high reliability. But in fact, we're an awfully long way off high reliability in healthcare, aren't we? I mean, we know that. That's why we're all in this room. This paper and editorial in the BMJ really showed that, and this is only 6 months ago, that there's a long way left to go. But the whole principles, and Monty Mythen's in the room with me, and we worked in the UK ERAS implementation, and really that covered everything from quality, safety, length of stay, everything. And this was really how I think we viewed what happens. We send a patient on their pathway, and any pathways, whether it's ERAS, whether it's sepsis, it's just basically lots of mini bundles, isn't it, of best practice. So you're trying to keep the patient on the pathway. However, despite the fact you do everything correctly, we still have some patients that decompensate and actually then go on to get complications. And we know that from Ghaffari's work that it's not the number of complications that health systems have, it's failure to detect them and to intervene that actually determines your overall quality figures. So the sooner you can actually detect this is happening, the better. So that's what the other thing we've built into the platform. So we utilized the EPIC SOFA scores. This was very challenging because no one would accept the fact that because we didn't have bilirubin, and which is part of the SOFA score, you couldn't have the SOFA score. And I kept saying, well, look, you've got to be realistic. Really, just it's always naught unless you're doing a liver function, because the only reason we do liver function is when we know there's something wrong with the liver. So that took an incredibly length of time to get everyone to agree on that, but we've got that. But you can see here that you've got, this is the clinical deterioration board, 4-hour trends. And then this gives you an idea of what the interface looks like on the right here. And we've got 4 patients parked on high watch. And then we can still use this screen in the middle. It's a widget screen. I'll show you how that works in a minute, because you can just spin the boxes and get whatever you want in them to save your real estate. But building best practice alarms was one of the key things, because I don't like all this noise from alarms. And this was a real opportunity, because we could finally not use the bedside monitor alarms. We could actually build our own alarms, some smart alarms. So this is what we did. So we built a whole load of best practice advisories. They're not simple 1+1 pass-through. They're integrated, and we're making them more and more complex as we've now got live waveforms in. And the other key thing is they're adjustable at a bedside level. So if we've got a cardiac patient, we can just click, all right, cardiac data set for that patient. Well, we might tolerate different, map, for instance. And there's a validation process associated with every BPA, which is basically, is it an artifact? Is it actionable? And if it is actionable, follow the action, and how do you do it? But the first thing we did was we used third-party software, and we actually got rid of 40% of the noise, which has been incredible. And then also we don't fire the alarms audibly. Nothing is audible. If you walk into our unit with 450 ICU beds, there isn't a single sound. There's no alarms, beeps, because it's just distracting, it's overwhelming. So we've integrated into the EMR the camera with one click there, and also this is we call it our widget screen. As I say, it's built in Epic Hyperspace. But it's a very elegant way of getting visual information, and it's no clicks. You just move the mouse over, and it will come up with the next level down as you go and do a deeper dive on each system. And then we've got integrated live waveforms, which is the first time ever in the world this has been done. I'll show you how we did that in a minute. But the thing I'm most proud of is actually governance. And that's the thing I learned in the UK, is if you don't have governance in your health system, everything falls apart, from quality to safety, everything. And so I think you're aware in Epic you have to validate alarms. The bedside nurses get overwhelmed with this. But we use unvalidated data. So it just comes through to us. And our data is not just firing on absolute values, it's also on deltas and trends. This one gives you an idea. This is the commonest false alarm pulse oximetry. I think you're all aware of that. We got rid of an awful lot of false alarms in pulse oximetry, but we still have to go in the room. So basically, if you get this up, you just click on the, so it comes up with the patient, pulse oximeter alarm, click on the patient, you click on the camera, within 4 seconds, you're in the room. You can see what's happening with the patient. You can see what else, you've got all their other waveforms. And so you really know what's happening with the patient with its artifact. So you can either click it off, that's artifact, or you're not sure, might be low, you can pause it and come back in 2 minutes and it will come back with a reminder. Or you can escalate it according to what you need. This is a bit more of a meaty one. This is hypotension, so we have a much more defined sort of escalation. But can you see we've actually built in this into the EMR? So no alarm can actually escape. And we have millions and millions of alarms, BPAs, being worked out every day on our patients, of which we action about 900. So that's 900 actionable alarms where we're actually stepping into a room, getting the bedside provider, and just doing, it might be a minor delta because the SATs are low and they just need a bit more oxygen, or it might be the fact that they've got a tension pneumothorax that's been undiagnosed and the patient's in distress and no one's recognized it. So this is the hypotension one. I can't see, I don't know if you can read that, but you can park it for certain numbers, minutes and things like that. But also it has other support like, is the patient hemorrhaging? It's got all decision support there built into this, layer upon layer as you go through. So that's the clinical governance. And then it's getting the right person to the bedside is the other governance. Those are the 2 main points of failure. So for every single unit at Penn, I have created this with my team, which is the clinical interaction model, which is everything. Does the data come in? Does it need escalating? Talk to the bedside nurse, validate it, escalate to the APP. Do we need the MD? Do we need the attending who's at home? And so this is a cardiac one, and you can see everything ends up going to the cardiac attending because that's what he wanted. So anything on that list in the middle, he wants to know about. So you can see that it's very powerful, and it's very different from each of the units, and it depends if we've got a fellow on a unit. If we've got a surgical critical care fellow, it's a very different algorithm to if you've got an APP-led system. And then at the top there, you can see we've got the patient population, what the actual staffing model is, what our staffing model supporting is. So to give you a little bit more flavor of the functionality. Now, one of the issues I think you're aware with Epic is they don't allow you to really show their product. So I've done some screenshots which have been approved, but I'd love to show you the video of the true functionality of this because it just saves all those clicks. You can just move your cursor over and everything pops up. So I'll show you what happens on the RT service and how we've also improved the workflow. So just to remind you, these are the dashboards. So we've got a proactive, a reactive, and a predictive sort of interface. These are the workstations. So I talked about unit level data on the left, patient level data. You can see there we've got the physiological waveforms in, and then the patient level interaction. So this is the unit data. I've shown you that already, but this is just starting to show you how the alerts come up. So they're color-coded. We know whether it's respiratory. We know if it's renal. We know if it's blood pressure. And also on the right here, we've got quality improvements. The top right, those two, that's actually a quality improvement thing that needs to happen. So that's vent orders. So this patient doesn't have any vent orders. So you can see it's not just about treating the patient. It's all about this proactive quality, making sure bad things don't happen. And this is what I'm most proud of. This is built this with Heather and the team. So this is the widget board. So you just scroll over it and it gives you a deeper dive. So you can see this is everything a respiratory therapist knows to round on every patient. So we have one RT who can round on 450 patients. Because this board, you just click it up. If nothing is in red, you almost go on to the next patient because everything's in order. It's that simple. It's everything from what type of airway they've got in. Are they ready for a spontaneous breathing trial? Do they need a sedation hold? What's happening to their vasopressors and everything? And then if you just move your cursor, you get a deeper dive, and these are the deeper dive, what automatically then drops down as your next sequence. So you can get all the information you need very, very quickly. So you can see fluids down the bottom there, and all types of fluid, whether it's TEN, TPN, fluids, or blood. We've got other integrated applications to achieve this. We have something called an ICU board, which one of our pulmonary critical care attendings has built, Barry Fuchs. It's a very good thing that we ran with in the morning on all the units. And it's basically a nudge board, just to make sure what's happening with the patient, everything from ventilation, SBTs, have they got low stretch ventilation they're ordered and things, and then other things about mobility. And then we've also used sickbay to get our monitoring waveforms in, and this can be done two ways. You can use it as a unit base with the Epic monitor, or you can actually bring it in through context-aware linking, which is what we did into the EMR. And it's useful because you can basically put it anywhere. I mean, I can have this all up at home. I can have all the ICUs up at home if I need to, but not that I do take my homework like that. But I'm just saying you can put it anywhere on anywhere where you've got basically a Cat6 cable. And then this is what it looks like. So again, we're taking all the noise out. So this is our neuro unit. So you can see different color coding and you can configure this all sorts of ways. And finally, to close the loop on quality improvement is always you've got to look at what you're doing, track the data, and give feedback. So the great thing is in this whole system is we've built this whole thing into the EMR so that we've got quality dashboards and something called Pendiver, so we can track the quality of the whole ICU across the health system and our own performance at the Tele ICU and how long we're using cameras for, how often we're using them. So finally, just to close, everyone thinks, well, could you do a whole ICU remotely, Mike? Well, the answer is yes, and we do. Because we actually have one of the first gift of life centers for organ donation. So we respectfully look after those patients. And because there's no FDA approval needed for anything, we actually partner with Medtronic, and we've got software now where we control all the ventilators remotely. So we admit the patients, we do all the orders, we do all the, so apart from having an A line and a central line, everything's done remotely with those patients, just with the bedside nurse. And this gives you an idea of what the nurses will see when we go into the room. So we have these big screens. So in summary, this is what we've built. You can see on the bottom left, the patient bedside provider to the traditional interface. And then you go up to the electronic medical record. But what we've done is we've pulled all this physiological data both into the, basically up to the cloud first and then back into the EMR. But also into the EMR directly through two different ways. But you've got this sort of, it's basically in a control tower model, isn't it? With the bottom right, where you've got your ERN, ERT, EMD, EPP interfacing, but also you can always get, using this two-way visual, audio-visual connection, the highest level decision-making into room for a patient immediately. So we're basically ensuring all patients are treated the same. There's no weak link, so it gives you high reliability. You've got both proactive and reactive detection. And obviously, it means that we intervene earlier, so you get better outcomes, and it leads to quality and efficiency. So really, if you go back to this slide, we've fixed it, because we set our own best practice and follow it. We get early detection, and recognition of life-trending changes. We escalate appropriately, both clinically and the bedside provider, and we've got governance. So nothing escapes, because it can't, because you can't get out of there unless you've actioned. And we've created that safe environment. So really, although I was asked to talk about the future, I think the future is already here. And that's been one of the great things about COVID, I think, is it really accelerated technology. So you can see we've got a fully integrated functional platform. The dashboards create this incredible user interface and speeds, proficiency of rounding, and also you get the data quickly. And we're trying to put this now bedside. That's what we're doing, is we're now building dashboards to use in clinical practice by the bedside. We've got best practice, we've got our best practice advisory, so that's been key, building those. And because we've now got waveforms, we can build even cleverer best practices, and also we can start doing things like AKI prevention, hypotension prediction built in, because you can take risk from the EMR and build it into the physiological genomic. You've got situational awareness, and as you can see, really, our next step, we've already gone into high-level care, and you can see from that last slide, we can even link this into wearables. So it's really a health system fix, and it drives high reliability, efficiency, quality, health equity, value, and safety. So thank you for listening. But it does take a village, so I'd like to acknowledge all these other people as part of my team. Thank you.
Thanks so much, Mike. That was a fabulous story. And we'll put the panel together at the end for some Q&A. So the next person I'd like to introduce is Julian Goldman. And Julian and I have known each other for quite some time. It's kind of amazing when I think about it. But so excited to hear Julian's story now, really extending the control of devices and information well beyond the walls of an organization. But Julian Goldman he's the medical director for biomedical engineering at Mass General Brigham Health System. He's an attending anesthesiologist in the MGH Department of Anesthesia, and the founder and director of the program on medical device interoperability and cybersecurity, also known as MD-PNP. PNP, I think, stands for plug and play, if I'm not mistaken. Dr. Goldman founded the MD-PNP program in 2004, so almost 20 years ago, to promote innovation in patient safety and clinical care by leading the development and adoption of safe, secure, patient-centric, integrated clinical environments. The program's new initiative on smart and autonomous medical systems at the MGH Center for Innovation and Digital Healthcare is addressing technology standards and safety of remote and closed-loop medical device systems. Please join me in welcoming Dr. Goldman.
Well, good morning again. I've been so engrossed and excited by all the presentations. It kept my mind off my own. So I'm going to refocus now. This is one of the best workshops I've been to in a long time. And so thank you to all the other folks. And Dr. Feldman, thank you for inviting me. I appreciate it. There are a lot of friends and colleagues, mentors here, and I hope to share some of the recent, historical journey and recent activities related to remote control. And I think a number of you will identify with some of the activities and stories. So as Jeff said, MD-PNP does stand for medical device plug and play, kind of the simplistic idea of enabling advanced system integration with safety. There are quite a few QR codes that you can use during the presentation or get a hold of later. Let's see what happens with the remote. So first of all, I have no financial conflicts to disclose, and here are a number of government-funded research grants that have supported the work that I'm going to present. You can see that this group are all from the Department of Defense, most of them in some way related to TATRIC, the Army's Telemedicine and Advanced Technology Research Center. Also, by way of background, here's a little bit of information about our program. Notice in the upper right corner, this is the same logo we've had since we started the program, and the small text says, "Getting connected for patient safety." So that has always been the focus. It's not about the technology, as we've heard numerous times. The technology is a means to enable better ways to care for patients. The program was founded almost 20 years ago. We'll be celebrating our 20-year anniversary next May, and perhaps you'll be part of that celebration when everyone is in Boston next year. You can see the URL for the website at MGH. If you Google MD-PNP, you might also find our old website, mdpnp.org. It contains very similar content. The impetus for starting the program was the MGH operating room of the future. And my friend and colleague, Dr. Warren Sandberg, is there. We were co-conspirators. We worked very closely together for several years in the OR of the Future. The OR of the Future was a wonderful clinical test bed to evaluate new processes, technology, teamwork, and we had hoped to also do really interesting next generation things with technology. And we did to some extent, but the barrier of the lack of interoperability really impeded the vision of some of the outcomes in the OR of the Future. So the leadership team that was involved with the OR of the Future at MGH and at CIMIT, CIMIT, helped us to start the program on medical device interoperability. So some of the kind of key things and outcomes that relate to what we'll talk about today are that we scratched our heads and said, what is interoperability? What the heck does that mean? What are we trying to connect to what? And of course, people think about, well, they want a blood pressure value and to be transferred to the electronic health record. Okay. But, you know, we're talking about anesthesia, perioperative care, high acuity care. We wanted to make things safer. We wanted to develop safety interlocks, so you shouldn't do something that doesn't fit, or stop an infusion if someone is becoming hypotensive or has a reaction to a transfusion when they're unattended. Or in the OR, there are numerous examples that we identified and wished we could do, such as synchronizing an X-ray with a ventilator to, you know, obtain an image at peak lung inflation, or maybe at when the lungs are not inflated, if that's better, and on and on. So to do things like that, you need to interconnect medical devices. You need to have real-time data moving around. You need to have security, and you need to do this without having to write new software every time you want to connect it to a new device. And that really is a very useful definition of interoperability. You know, you go to Costco, you buy a new printer, you bring it home. You don't have to hire a software developer to write a new, driver to connect your printer or anything else. You may have to configure it. You may have to call tech support. You may have to hit your head against the wall a few times, but you don't have to write new software every time. So with that definition of interoperability and with this vision of what the capabilities should be, we realized that the path forward would be a platform-based approach, which we called, with the help of many collaborators over several years of meetings, ICE, for the Integrated Clinical Environment. So ICE concept is a platform with connected medical devices, sensors, actuators, and then connected to other systems like an EHR or whatever else. Now remember the year we're talking about here. This predates the iPhone. So this predates the idea that you have a pocket platform with apps that you just download and you connect things. This is why it took a team a few years, as we thought, we just don't want one-to-one connectivity and call that interoperability. No, we need platform-based approach. So all the work since then has been on advancing the notion of platform-based approach. So first was the ICE standard, which is published as an international standard in 2009. We developed open source software under a $10 million NIH quantum grant, which we call Open ICE. And for those of you that are into programming and whatnot, just you could search for that and download the software from GitHub. There are commercial implementations that conform to the ICE standard, and we'll see at least one of those in the presentation today. And then we built out the lab, and our lab, so just as the OR of the Future was a clinical test bed, our lab is a preclinical test bed. So we could evaluate technology. It's very hard, and we learned in the OR of the Future, working on the plane while you're flying it is quite challenging. And you need to overbuild the clinical environment to accommodate the ability to iterate technologies. You also need the clinical test bed. So it isn't our team's job to build the medical devices and to do everything. We work closely with medical device manufacturers and other innovators, but we do have the ability to simulate from an engineering standpoint and a network standpoint, a medical device simulation standpoint, the clinical environment to simulate, including workflow. So that we are very involved with collaborative prototyping and projects with industry. We also have collaboration agreements with several federal agencies that allow us to collaborate in the pre-competitive space to help advance things, to make it easier for products to come to market safely and hopefully to interoperate. So this is the front page of the research collaboration agreement that we have with the FDA, with CDRH. Dr. Sandy Weininger is the co-PI at the FDA, and I'm the co-PI at MGH. And as you can see from the text, without necessarily reading all the words, you can see the scope. This is public, and the idea is that our work is intended to be shared publicly through publications, and especially to inform standards. So speaking about standards, these are the covers of the original ICE standard from 2009 for the integrated clinical environment, which is, it's an architecture standard on the left, and on the right is the standard was transferred from ASTM to AAMI, where it is now published as 2700-1. So what is the integrated clinical environment conceptually? Well, think of it again as a platform, as you see on the right. There are devices connected to patients. Some of those devices are medical devices, but many of them are not. You need environmental sensors, position sensors, many of the things we talked about. All of that needs to be interconnected. One could call it a medical IoT, totally reasonable term, because it's an IoT being used to support medical care. The ICE supervisor is the app platform at the top of that box, and that's what people interact with. And on the left, it connects to the rest of the world in different ways, or the rest of the hospital. But the ICE is patient-centric. That's the point. And that, therefore, it could be in an ambulance, in a home, in a hospital at home, in an OR. It's not about where it is. It's about the architecture and the intended functions. As you see at the list on the left, a number of kind of self-evident things that come with an ICE, whether it's security, the ability to isolate it from the environment if needed for security, real-time data connectivity, high bandwidth, common time stamping. And then I believe there's a pointer here. Yeah. Okay, and if you look, there's a data logger here. So an integral part of the standard is the ICE data logger. When we heard about data logging and black box recording, why is that so important? It's important for a few reasons. It's important for, not just for patient care or other things. You need it for the environment. How many of you who are device manufacturers or platform manufacturers would ever consider interoperating with another company, with another device, someone else developing an app, and someone else with developing a platform, and look at your liability exposure? And how in the world would you assess the system and keep improving it if there's an accident or a failure? So a data logger that is a common data log of all the communication is essential in order to be successful for medical legal reasons. It's also a way to assess whether devices are interoperable. If they can't transfer the data to a common data log, well, I don't think they're interoperable. So those are some of the key elements. And by the way, the data logger standard was also published as AAMI 2700-2-1, also under US government support. We also, along the way, developed OpenICE. That's the open source software that I mentioned. And this is just something that looks pretty, but we already talked about the content of the slide. So with that as a bit of a background, let's move on to the story of remote control. So I was minding my business one day at MGH, taking a break on a Friday, enjoying the delicious peanut butter and crackers in the lounge, when my phone rang and I could see that it was a Washington, D.C. area code. So I thought, well, I have 3 more minutes. I'll see who it is. And who it was a call from someone that I knew who worked at the Office of Science and Technology Policy at the White House, who said, we have cases of Ebola showing up in the US. What could your program do to help? Is there a fit? And we had been looking at pandemic preparedness technologies in collaboration with the Global City Teams Challenge and with NIST. So the first phone call I made was to the FDA, to someone who was in charge of all hazards response there. And the FDA said, we're happy to be on board if your plan is to bring together medical device manufacturers. Because without the FDA at the table, how many folks would really engage if they thought it was a dead-end pathway? So the FDA signaled encouragement and committed to participate. And over the next 3 or 4 days, we identified 20 different collaborators, mostly medical device manufacturers, but also academics and others, who came together and completed prototypes that included remote control of medical equipment. And that was done in our lab and is available online. This is one of the websites from the time in 2014 from WCVB TV that shows the project, that shows the demonstration, and we're going to see whether we could play, that's just some lab pictures. We'll see if this plays with audio. Just gonna play the first 15 seconds or so. Now, are you able, is there a special incantation or? It worked before. You have to click on it. So as you can see, we can rely on technology for patient care. There's nothing at all to be concerned about. And if it doesn't play, we will move on. But it did play before. We've all heard that before. Can I get some more coffee? Okay, we're going to move on. Now it's playing. I can't hear anything, though. There's jazzy music. Louder.
Think about this. If a TV can have a remote control, why not a medical device? The White House challenged companies nationwide to come up with high-tech ways to improve the country's
Okay,
ability to treat
someone needs to
Ebola
click on the
patients
OK.
safely.
And new at 6 tonight, News Center 5's
Please.
Kelly Tuthill got a sneak peek in Cambridge
don't see-
ahead of
only
a
I see it.
presentation tomorrow in Washington, D.C.
Can we go back? I can go back. So I'm getting a box on here that's for this device. It's not letting me control the slides. Okay, that's better. Thanks. No. Okay, so did you hear the one about the anesthesiologist that was trying to control the ventilator from outside the room? All right. Could we skip ahead? So I can't control anything. Okay. All right, so we talked a little bit about that, and that's the video, and I'm going to skip it. Try. Well, it's magic.
Think about this. If a TV can have a remote control, why not a medical device? The White House challenged companies nationwide to come up with high-tech ways to improve the country's ability to treat Ebola patients safely.
And new at 6 tonight, News Center 5's Kelly Tuthill got a sneak peek in Cambridge ahead of a presentation tomorrow in Washington, D.C. Take a look.
Imagine
All right,
sending
so
a
I'm going
robot.
to stop the video, going to the next slide, because there isn't enough time to watch this, but it's all online, and there's a lot of other videos that we'll just see the links to. This was just to give you a taste of what it's about. So the real message here is not the video, right? The message is that it is possible to work together, to bring a community together quickly, to respond to emergency situations, and to have the FDA engaged and supportive, as you can see from this letter of support written by Dr. Jeff Shuren, the director of the FDA Center for Devices and Radiological Health. And they did have a senior person in our lab most of the week engaged with manufacturers the whole time. Okay, so now we move 5 years ahead. Okay, so remember what happened 5 years before with Ebola. Move 5 years ahead, and we all seen these pictures, and we all know what we had to do. IV pumps were moved into the hallways with a couple of miles of tubing. People stretched the vent control panels to the best of their ability with ventilators that permitted it. There were problems with hearing alarms outside the room, and of course, delays due to donning and doffing PPE. So that was the situation. And interestingly enough, Nihon Code and Orange Med, prior to the pandemic, had already obtained a 510K for a remotely controllable ventilator, which has a second screen, a second GUI, and a 10-meter cable. So you can see in the photo the white cable that's running from the second screen outside the room to the ventilator inside the room. So the FDA was willing to clear what was considered kind of a lower risk application. Instead of connecting to a network to a ventilator that was far away, you're performing near patient remote control with a dedicated cable connection. So that was also a required line of sight. So you could look through the window, right? Think about what would you change on a ventilator if you can't see the patient. Some things maybe, but maybe not everything. And we'll talk a little bit more about that. The other very important development that occurred is the FDA in the spring of 2020 released 3 immediate in effect guidance documents, one for all of them for remote control. So these documents permitted manufacturers to add remote control to already cleared devices, to devices that were already being marketed, ventilators, infusion pumps, and monitors. This provided a pathway for rapid innovation and was almost certainly based upon the experience with Ebola and the years of comfort that was obtained with the concept of remote control. In one meeting that I attended at the FDA around 2010 or 12, at the end of the meeting, the folks at the FDA said, well, we kind of support the idea of interoperability, and this is making a lot of sense for safety, as long as you don't plan on remotely controlling a device. So fast forward a few years, and I think everyone has just gotten more comfortable, and the key is demonstrating the clinical benefit, right? Because adding risk, if there is addition of risk, without a clinical benefit is pointless. So Medtronic released software and an update to the very popular PB980 ventilator to enable remote control also at the same time in the spring, in the winter of 2020. And so we were in communication with Medtronic, and they shipped us a ventilator with the modification to our lab. And we tested that in our lab to see what would be required for clinical deployment for connecting a remote control using the Omni tool that was provided. Now, this is a network-based connection, so you no longer are limited to line of sight, but you do have to think about the network connections and the implications of who has access and is there adequate security and so forth. So this is the installation in our lab, and there's a Vimeo link there when you can see the details. But notice that we have our volunteer mannequin who's well-dressed, mechanical lung, the ventilator, and we added a webcam to see whether visualizing the changes would be helpful. And so this is a screenshot using the webcam of the remote control of the ventilator, and when we did our first testing of the system. We then shared our results back with Medtronic, shared it throughout the hospital system, and ultimately, as I visited hospitals, I saw the implementation. So we have the historical efforts that groups like ours have made from the research standpoint to push the envelope with the engagement and support of the FDA. And we have the change in the FDA allowing for innovation, and manufacturers then taking advantage of that to try to advance capabilities in the market. There was a missing piece. The missing piece was that the FDA really needed standards to help evaluate the new devices or the new capabilities against standards. So the Amy supported the formation of the COVID response team, and we formed the team, and we met, I don't know, maybe half a dozen times, maybe more per week for several weeks, and wrote a series of standards related to a whole range of emergency use devices, including remote control. This is also available freely online, and you can see the list of members and participants in this initiative. And this is not a regular standard. This document is a kind of a lightweight standard that was published very rapidly with very quick peer review, and just to get it out as fast as possible. So this type of document from the COVID response team, again, these are all available for free, but it isn't really the long-term standard that one would use and that would be accepted by manufacturers and the FDA regulators and so forth. That requires a much more complete standard. Now, I'd like you to look at, this is the kind of quick standard from the spring of 2020 on remote control. And since this is a talk about safety of remote control, I'd like you to see the different safety sections. It requires disclosure of the architecture. The manufacturer has to disclose how you should connect this. It has to address the degradation or loss of information. What if you pull out a cable, trip over a wire, or lose the network connectivity? It requires an understanding of who is authorized to use the remote control and electromagnetic compatibility. Now notice on line 237 on the bottom right, it says, conformance to testing for electromagnetic compatibility is recommended but not required. Why would it not be required? Because this was an emergency use process. There wasn't enough time to do all these things. There wasn't the capacity in the testing world to test all these things. So we really took a risk-based approach of what were the likely hazards and what could you test in the time allotted in order to get this out the door. We also have been, at the time, we moved quickly, and now we're returning to assess the concept of near patient versus far remote control. What new hazards emerge if you're controlling something in an area where you can't rapidly enter the room, or you can't see the patient, or you can't see the device? So we don't have the time to go into all that today, but just you have to think about what changes in your world if you are moving away from the device to remotely control it. And does it matter? And in many cases it doesn't, but in some it might. The quality of the information that you see might matter greatly. Like, how much information do you need to bump up FiO2 on a ventilator? Maybe not a lot, at least if it's transient until you get to the bedside. But maybe if you're going to adjust the trigger pressure on a ventilator or the timing to deal with asynchrony, you're probably not going to be willing to do that unless you can see the patient and see vital signs and see real-time ventilator waveforms. Doesn't mean you can't do it remotely, but you might need more information. It might have to be real-time. So this is the current standard under development. And for those of you who are interested in getting involved, we welcome that. And this is an AMI standard. This is the table of contents. Just want you to scan that so you can see the kind of the scope of what we're considering. We meet every 2 weeks to finish the standard. We also changed the scope So it isn't remote control of all medical devices. It's limited to ventilators and infusion pumps, in part because the immediate in effect guidance is going to time out this month. It actually timed out in May, but it was extended for this month. So now manufacturers won't have an easy process for adding remote control to these devices, and we're trying to help with that, as is the Society for Technology and Anesthesia in support of that. Now, the other thing that's important for safety is information and instructions. And so, Jeff, you said, what are the things that we do? What can we take action on here within the APSF Stoelting workshop? Well, in 2013, in a panel, we started to discuss the idea that we don't have papers at the point of care. We don't have the information we need, and that maybe QR codes could help with that to provide rapid access. So based upon that, and based upon, I think, a poll in the meeting in which the consensus was QR codes actually are a good path forward to help with the use of equipment with instructions for safety, in 2015, we formed a team from several institutions and presented at the ASA, a scientific exhibit on the use of QR codes for medical device point of care product information, which was awarded a third-place award. And we demonstrated linking to videos and instructions and so forth on a whole range of devices. That's a picture of the poster, and this is all available on our website. And Draeger company permitted me to show this picture of a pre-release product. The 510K is pending, but notice there's a QR code on the screen to help you look up a video online and get information as needed in patient care. So let's face it, we've been using QR codes like constantly. So it's taken a little while for medical devices. Now, next step in this journey is NETSIN, the National Emergency Telecritical Care Network. And NETSIN is a DoD-funded initiative to enable telecritical care. As you can see from the center photo, it lays out the challenge of not having sufficient intensivists or ICU beds around the US as COVID was ravaging the country. So they funded a portfolio of research. I listed some of those things early, and also focused on TIDE, technology in disaster environments. So as a part of our deliverables being funded under the NETSIN program with a group of collaborators who some were independently funded, we held 2 demonstrations, live demonstrations of remote control. One of them in December of 2021, in which we ran live simulations of clinicians around the country, for example, an intensivist at Madigan Army Medical Center, controlling and supporting with telecritical care, real-time communication, as well as remote control, supporting simulated care with a mannequin, and we did this in multiple locations. So this slide at the top is entitled December 17th, 2021, and this is a list of the videos. It's actually about an hour and a half that was cut into chapters, and you could watch all of these in your free time, especially if you have insomnia. So those are easy for you to reach and watch. This next slide shows, this is the second demonstration. This is from November 2022. And this is also a group similarly of specific, carefully crafted use cases to demonstrate the applications of remote control for different things. Now, I'm just going to run through some high-level parts of this. We don't have time to go through all of those. This is the first one with, again, I'm using the word far remote control to contrast with the near remote control with a cable connection that existed previously. So in this case, in the top left, that photo is a photo actually from Nihon Koden's lab in Santa Ana, California. And we used a commercial ICE platform from a company called DocBox, which has also been funded. So these are the results of research, which is an IoT platform to control the device from our lab. And you can see the script below of what's occurring, and these are the different folks in different places. The upper right corner is our lab. Bottom screens are the user interface from DocBox. And by the way, I won't go into detail now, but the study was performed with respiratory therapists for the usability of remote control for the system. So it requires that as well. So I think, is this going to play? So this is a simulation of far remote control of controlling the NKV550 ventilator, as we discussed. This on the left is a picture of the hospital, the NK Community Hospital in Santa Ana, California, and we'll go live to there in just a moment. In that hospital is the ventilator, the patient simulator, and a DocBox IoT ICE platform that will connect the ventilator to here, to the remote MGH-MD in Cambridge. And by the way, we'll all be playing different roles and without actually changing hats, so hopefully it'll be easy to follow along. All right, with that, we're going to switch to the NK hospital, and let's get started. Let's start the simulation.
Hi, Dr. Goldman. This is Miran from the Nihon Community Hospital.
Hi, Mehran. How are you today? What's up?
Doing well. We've got a patient here on spontaneous mode who's having trouble breathing on his own, and his O2 saturation levels have gone down. And our respiratory therapist is currently assisting other patients, and I was wondering if you could help us.
Mehran, sorry to hear that. And I'm happy to say that we're available. I'm here, and next to me is a respiratory therapist, Alyssa. And if you press the button that allows us remote access to your ventilator, we'll take a look at the data and see how we might be able to help.
I will do that right away.
All right.
Done.
All right, thank you. Well, let's see. We have to now connect to your ventilator, so let's navigate through our user interface.
All right, so this is at the NK Community Hospital, correct?
That is
Mehran,
correct.
is that the location? Okay, thank you.
Great. All right, I'm going to launch the doc box next to your patient there, so I can see the doc box. Just give it 1 second. It may take a second to load.
Sounds good.
All right, is your patient Fernando Powell?
That is correct.
Great. I'm going to switch over to the ventilator screen.
Now let's look at the ventilator. It looks to over here, just looking remotely, that the waveforms are flat. Looks like the patient is not making any efforts to breathe spontaneously, and the ventilator isn't breathing for the patient either because it's expecting the patient to breathe. So that means we'll have to change the ventilator mode to something that breathes for the patient. So let's take a look at what we can do from here.
All right, you'll see on the DocBox system, we have that apnea alarm, like there is on the ventilator at Neon Coden. And we also have those flat waveforms that we see on the ventilator.
All right, let's change to a mandatory ventilation mode.
All right, I'll come down here to the vent modes. Here are the available vent modes to me.
AC, VC with volume control.
Great, I'll select and
Good.
then save.
Good.
And in a second, we should see the waveforms populate and the alarm turn on.
Looks to us like the ventilator has been activated and is breathing for the patient, Mehran. Is that true?
It is correct, and the patient is doing better.
Excellent. And when we look at our local screen, actually the waveforms look a little different on our local screen versus yours at the bedside. Alyssa, is this typical when you're controlling something from remotely, or what's going on with those waveforms?
Yeah, so this is really just an interim version of the software. So the waveforms are not quite accurate or precise, but we are still developing this software. So in future iterations, we will see more accurate waveforms.
Okay, well, it looks from here like the patient's doing okay. Mehran, is everything all right at this point?
He seems to be doing all right. I'll keep an eye on the O2 saturation.
Okay, well, we'll still be here, and if you need more help, please don't hesitate to contact us, okay?
Will do. Thank you so much.
End simulation. Okay, so that's the first simulation that we just covered. Thank you. You couldn't hear me through the remote. Okay. So, you know, this was live. I mean, the delays were real, but everything worked. It was real, all real, except for the patient. Okay, that's great. But how do you then test and assure that, you know, what is the impact of network connectivity and the internet on the system? So this is an example in the lab of how we set up our test. It's the same NKV 550 ventilator, a mechanical lung, a dock box system. But on the right lower corner, you can see that's an internet, that's a web browser-based interface, the one that was just used in the simulation. What we do is we have network setup that includes special appliances that allow us to interfere with network connectivity. We can change bandwidth and add jitter, latency. We can do that unidirectionally in a controlled manner and see how it affects the performance of these systems. So we've been testing telecritical care systems like that and then reporting it back to the vendor. You know, what do they think the spec is on what kind of connectivity you need, and what do we see the spec is, and what is the impact on performance? and usability, and does it affect the waveform quality or cause delays, or when do things fail, and do they fail gracefully or in a predictable manner? I won't show video now, we don't have time, but just to give you a flavor of things that we also did, this is an example of transferring a patient by ambulance, and this was done in Toronto and managed by an intensivist at Madigan, Dr. Chris Colombo at the top, and some of you know Dr. Stephen Dane at the bottom. He played a paramedic in the simulation. We also worked on a common user interface. Imagine if you don't have to learn the interface for every different device, every infusion pump and ventilator, if you're performing some basic setting changes. So we developed a common user interface in the lab, and that's Dr. Dave Arney in the mask in the upper left, demonstrating it, and we did this, showed this with a AccuPump, as well as with the pump that you see from Aton Medical. So I'm going to run through these quickly to give you a feel for the other simulations. This is an example of injury in the field. This is the point of injury. Medics arrive and perform tactical combat casualty care at TCCC, move the casualty from the point of injury to the field hospital, and prepare to evacuate the casualty in a M4 UAV medical evac pod that's designed to go under a UAV to transport a patient. Pretty cool stuff. And we did this with Fort Detrick live, and you can see the setup with the medic on the left with 4 casualties, one of whom had to be evacuated, one of whom is in surgery behind them. And so we ran through the simulation. Again, it's all available in the videos online, in which we received data from the Philips monitor, controlled a NeuroWave IV pump, the AccuPump, as well as the Nihon ventilator to help support that medic who was having difficulty, and then continue to provide remote support with the drone, with the evac pod, although it didn't actually fly, unfortunately, in the simulation. And so we do that and then continue this work in the lab. And there's a photo, that's a fake ICU window to show Dr. Dave Arney outside the ICU in the lab. And the setup that we've used for that. So not going to go into any detail here, but I want to wrap up by mentioning something that may only make sense to some of the engineers who are used to doing safety assessments of systems. How do you actually prove these things are safe? So there are tools that exist to help you prove from an engineering standpoint that something is safe. One of them is a safety assurance case. The FDA really promoted the use of safety assurance cases for IV pumps, but they use in other safety critical industries. And so there's a brief description here of what it is, but I think it's easier with this text to understand that it's an argument, it's a logical argument about how you're proving your system is safe and so on. There are tools that help you do this. We're using one, there's from Adelard and GuessNet. We use a GuessNet tool, and part of our research is to develop a generic template. So this is another example for the APSF of how can we collaborate with industry. So there was a common risk assessment and common understanding of risk mitigation, so that when you want to bring products through the regulatory process, you can get agreement that there's been a consensus of these are the areas of concern for remote control, and this is how you as a company are going to mitigate those through information, through data quality, through security, whatever it might be. And so we're developing this with a generic template for remote control of medical devices. And then, again, may only make sense for those of you who've thought about this kind of this concept of safety assurance case, but we've developed this with all of the associated arguments and claims of why a system will be safe. There's a top level claim, and then you decompose that to the safety arguments. So not something we'll go into in detail, but I wanted to convey that we're pretty down and dirty into the details of what it takes to have safe systems. With that, I'd like to thank some of the key members of our team, and the QR code will take you to the website where you could learn about some more of our collaborators and so forth. And if you're interested in participating in the AMI committee, please contact me or Dr. Weininger. And I thank you very much for your time and attention, and many of our colleagues here for your support and collaboration.
Thanks so much, Julian. Great work. So nice to see all that coming together after all these years. Congratulations. We'll convene as a panel at the end. I'm excited to introduce our last speaker this morning, and who's going to really focus on the provider end of things, which is, I think, one of the most burning platforms we have today. But so we have Dr. Robyn Begley. She's the Chief Executive Officer of the American Organization for Nursing Leadership, AONL, and a Senior Vice President, Chief Nursing Officer of the American Hospital Association. In her role at AONL, she leads a membership organization of more than 11,000 nurse leaders whose strategic focus is excellence in nursing leadership. She oversees a number of key initiatives involving workforce, quality and safety, future care delivery models. In addition, she works collaboratively with the AHA to ensure the perspective and needs of nurse leaders are heard and addressed in public policy issues related to nursing and patient care. And she also leads the AHA Workforce Initiative. Very fortunate to have Robyn with us this morning.
Thank you. Oh, okay, I got this one and I have a lot. Can you hear me? Great. Okay, and here's my clicker. So it's great to be here today. When Jeff and actually Patty Riley reached out to me last year, you know, I said, what would you want me to present to this group for? Never been here before, although I've heard of the thought leadership that comes from this group, and you just can't say no to Patty, right? So here I am. We talked about, you know, what I should be addressing in my remarks, and you know, Patty said, please come and participate and you know, learn. So I was really thrilled that I was able to spend yesterday here. And last night I feverishly sort of rewrote what I was planning on addressing today. I learned so much yesterday. And you know, it really is helpful, I think, to go to a conference or a convening where it's not your tribe. So, you know, this is, you know, thank you for inviting me. I learned a lot, and I would recommend that maybe you attend something, you know, in the next year or so that is, you know, related to what you want to learn about, but also maybe not the people that you usually connect with. So a little bit about myself. Thank you, Jeff, for the introduction. I've been with AONL AHA for almost 5 years. Prior to that, I was a nurse leader. I think the Philadelphia area is very well represented in this conference. I worked for 35 years at AtlantiCare Health System in southeastern New Jersey, the last 20 as chief nursing officer for the system. Prior to that, I had, you know, started my career in Massachusetts and a little bit of time in New York State, where a maternal child, you know, area was my clinical love. And I still, when I go to the, you know, labor and delivery areas, when I tour, or the NICU, I mean, it pulls at my heartstrings because that's really where, you know, where I love to be. So I did work labor and delivery, postpartum, NICU, worked in a prenatal clinic for a while. So I kind of had the whole scope, did a little stint in peds, and had the opportunity to interact with anesthesia professionals. So, you know, I think I know a little bit about your world. So I am going to make sure I understand this technology. Yes. So I'm going to talk mostly about workforce, a little bit about the remote provider experience. And then I guess I just would like to end with, you know, with a little bit about my observations from what I've learned over the past, you know, past day. So here, and I might have to put on my glasses because the slide is, I thought I brought them. Yeah, I did. The slide looks tiny on this little screen. Massive pressure on the healthcare workforce. By the way, I have way too many slides, and you're welcome to them after, and I'm going to buzz through a few of them. But we know that the last couple of years has been absolutely devastating. And as I, thank you for making them bigger, as I, you know, as I travel the country, which I do pretty much for, you know, in this role for my job, that's what I'm hearing. I hear it from everyone, not just nursing leaders, but we're hearing it from, you know, all members of the C-suite, from the nurses and providers, and it's really a challenge. You know, compounding that, the past 2 years in particular, are the health system financial pressures. And for sure, there are the haves. You know, we know about the health systems that have lots of resources and, you know, not just a year's worth of cash on hand, but, you know, way more than that. But we also know, and I know personally, you know, the critical access hospitals, the rural areas, the community organizations that really are worrying about payroll pretty much month to month. So it really is challenging to do the work for the future when, you know, you're really immersed in the day-to-day. So we know that the workforce issues, you know, are exacerbated now, but we've known about these for a while. And as you can see on the screen, some, you know, some statistics that are a little bit older, but just goes to show you that pre-pandemic, we knew, baby boomers are retiring, and, we knew the cyclical nature of our business around workforce, and we were making preparations. However, we know that, the pandemic just ripped the Band-Aid off and created challenges like I've never seen in my career, and I'm betting that pretty much nobody in this room has either. So we can see prior to the pandemic and then numbers with the pandemic that the hospital staff turnover rate, that's all staff, has really increased. We haven't gotten the final 2022 numbers yet, but when we do for nursing, and when we look at the average RN vacancy rate, that's a tough one. So in 2023, we've seen a little stabilization of this, which I'm happy to report. But again, it's very regional. Some organizations have, we're going to talk about contract labor in a little bit. Some have really reduced their utilization, have been able to, to shore up their regular full and part-time staff, and others are still struggling. So here's just a very interesting perspective too. Our nurse managers, our frontline nursing leaders, have huge responsibilities for running their units, worrying about outcomes, worrying about the well-being of their staff, and also their, patient satisfaction, budget, you name it. Usually there's a small number of new nurses that they're, onboarding, making sure that they're shepherding into, becoming competent nurses. But if we look at the staff, the tenure of nurses, of frontline, 12-hour shift working nurses is really scary. And I know from my conversations with, my colleagues that we have nurses precepting that are nurses for, less than 2 years. And they're now the preceptors of the new nurses that are graduating. So, and education has really been challenged in the last 3 years. So the nurses that are graduating, the level of competency that we expect with them is really not what we are finding. And that is not just for nursing, that is a worldwide statistic right now, that folks are graduating and are not as well prepared for any job as they are, despite the fact that they do pass their NCLEX exam. Now, the next slide talks a little bit about the Great Resignation, and this is for all sectors. It is not just, healthcare, but it does include healthcare. And we know that many folks in the workforce have really reevaluated their life. And do they want to switch careers? Do they want to reinvent themselves? We're seeing still lots of gig workers. Folks are saying, I don't want a full-time job. And, especially, when we see some of the financial benefits in healthcare of people, traveling, it's hard to, for the folks that really want to maximize their opportunity to earn, it's hard to really have an argument. I've heard this week that, and I don't know if this is politically correct to say, but sign-on bonuses for CRNAs are approaching $100,000. So, I mean, that's just pretty unbelievable. Staff nurses too, $25,000, $30,000 sign-on bonuses in some areas. It's really pretty amazing. And we saw lots of people leave the workforce, and I think I have a slide later on that shows that particularly the 55 and olders left the workforce, and we're really not seeing them come back in the numbers that we had hoped. So, we know that we are faced with generational, we've got now 4 generations in the workforce, but the things that Generation Z healthcare workers want seem pretty, from my perspective, and obviously I'm a baby boomer, but they seem pretty reasonable. They are comfortable with technology. They want to work for places that really do embrace technology and have the latest and greatest. They want work-life balance. That is very clear. Greater access to mental health support. The stigma that some of us older healthcare workers maybe feel about seeking behavioral health does not exist in our younger workforce, which I think is a good thing. They really value diversity, inclusivity, and belonging, and have a strong sense of social responsibility. So all good things. sometimes I think that, we bemoan the work ethic of the younger generation, but you know what, maybe they have things, pretty well thought out. Younger and older workers are decreasing, as I referenced earlier. And the younger workers, we know from a wage perspective that, you can work at Walmart, you can go work at Target, at, Southeast, from my area, it's the Wawas and the 7-Elevens. And, that might be deemed to be a lot more pleasant work than entry-level hospital work. So we really have to work on that. And that's one of the things I'll talk about in a little bit. The next slide, I think, is probably one of the most important slides that I have for you all today. And it's not just about demand or supply, it's also demand. So by 2030, all baby boomers will be over the age of 65. Ooh, I just can't believe that. And the younger people in the room are probably like, yes, finally. But this is, pretty startling. And the last bullet point, the population of our super seniors, 85 and older, is expected to grow nearly 200% by the year 20, that's 60, right? Yes, can't see it too closely. So we know the care that our super seniors require. When we look at our hospitals today, our nursing homes, who's it filled with? It's filled with, our seniors and our super seniors. So the demand that's going to place for healthcare workers is really, huge. So, despite the fact that we're seeing care migrate outside of the hospital walls, which I think is a positive trend, I think our hospitals are still going to be pretty darn full as well. I think the jury's out about remote work. You may have read over the last, especially couple weeks, that the tech companies are saying you got to come back to work, including Zoom, which I think is pretty funny. Also, the financial institutions, JP Morgan Chase, all the heavy hitters are saying we want our people in the buildings, and yet there's a lot of pushback still. Many healthcare organizations basically said we are allowing those, during the pandemic, they said those that are back of the house, we are, going to send them home and they don't need to return. And I know there's a lot of organizations, billing and coding and a number of other functions that, do not occupy hospital property anymore. We know that some of our healthcare workers are also working remotely. We're going to talk about virtual care, virtual nursing in a little bit. We're not sure about, I think the pendulum is still kind of out there, but what we do know is that in healthcare, we're competing with those industries that have said, okay, there's more flexibility to be had here. I know there's also questions about productivity, and we have a little bit of mixed messages here. So I think the jury's out, but I think it's something we really need to watch. Top 10 patient safety concerns. Every year, ECRI produces a list, and I know yesterday we heard from, the chief medical officer from ECRI, but in 2022, we saw staffing shortages really top the list. And this year, the issues around, workplace safety and workplace violence really, very disturbing trends and things that we see and hear across the country. I think we'd be naive to think that healthcare would be immune from what we're seeing in society and across the country. And, it's really, so concerning and so distressing. And if you look at the statistics, I think healthcare workers, nurses in particular, had 5 times the rate of occupational injuries related to, to their work setting than the average person who does not work in healthcare. So we need to do a lot of work in this area. Last year, ACHE did their annual CEO survey, and I think for the first time in many years, staffing was the #1 challenge, workforce challenges. Usually it's reimbursement, as you would expect. Last year, it was workforce. With shortage of RNs topping the list, and 90% of our respondents, responded in that way. But when you look down the list, it's really a shortage across the board. It's not just nurses. It is clinical folks as well as non-clinical. So lots of work that we need to do related to these challenges. And for some reason, I think the next slide looks like I have some duplicates, but, and apologies here, but our AONL we have a longitudinal survey that's actually our 5th iteration will be going out this fall. And this is last fall's results, but we asked nurse leaders and had a really great response rate. What were their top 3 challenges? So it's their staff. They're worried about the emotional health and well-being. It's staff turnover. And in the beginning of the longitudinal survey, at the beginning of the pandemic, there were layoffs and there were furloughs. And so we kept the question the same, but it really is related to retention and turnovers. And the third is travelers, and our contingent labor still continues to be a source of real challenge for our nurse managers, and a number of other lists as well, a number of other items on the list, as well as we had a little bit of difference depending on your role. Okay, so every 2 years, the National Council of State Boards of Nursing produces a report. This year's report, which was released in the spring, is extremely concerning. 100,000 RNs left the workforce due to stress and burnout, over and above the normal number that we would expect to see leave, by normal attrition. This is a great report, by the way. This is just a couple, of line items, but I would encourage you to go to the original report. Very concerning, 610,000 reported their intent to leave by 2027. Now, intent to leave in all surveys related to workforce is never directly correlated to who actually leaves. But when you look at, what is the mindset of the nurse if we have 600,000 nurses that say in the next couple of years they want to leave? By the way, we have 4.1 million nurses in the US that are currently licensed, registered nurses, and we have about 2.1 or 2.2 million that work in the hospital setting. So a good half, a little more than half, still work in hospital and health systems, and the rest work in many different settings, including in industry. And I think, we have some nurses here who are examples of that. Our younger nurses are especially distressed. We will see that in another slide coming up. Burnout, emotionally drained, et cetera, is very concerning. And 3.3% decline in the US nursing workforce, we've seen in the past 2 years. So this is something that we really need to keep an eye on. We need more nurses. We know that from the demographic information that I gave you a little bit ago with our, aging population. We can't afford to have nurses leave and nobody to replace them. Also, our nursing school enrollment, this is a study by the American Association of Colleges of Nursing. They put it out every year. Last year in 2022, we turned away 78,000 qualified applicants. Due to lack of faculty and training sites. But more troubling is that little red dot on the right-hand side of the screen. Our number of students in entry-level baccalaureate programs decreased by 1.4% last year. This is the first time in 20 years that we've seen a decline. So we had a real challenge, right before the year 2000, we had a couple years where we really saw a decline. There was a really big promotion. You may remember Johnson & Johnson's Image of Nursing promotion. There was a lot of money generated towards supporting the nursing profession. And we see from the green bars that it really did have an impact. Also, that was the years, 9/11, which was 2001. There was a sense of renewed purpose towards the service professions, and we saw, and healthcare, and we saw, you know, a pop. But this, we're keeping our eye on this because this is very concerning. Talked a little bit about burnout and mental health. My survey that I referenced earlier from AONL looked at our self-reported information from our different levels of nursing leaders. It may be no surprise to you. Our last survey in the end of the summer last year, early fall, showed that our numbers had improved a little bit, which was a good thing to see. We'll see what this year's show. But the nurse managers, those managers, you know, leading our staff, that really are, you know, and I did that job probably for 3 years earlier in my career, and I can tell you it was the hardest job I ever had. You know, so they are pushed and pulled in all directions. They're getting directives from above. They're trying to keep their staff happy. They also really care about their, you know, their patients. I mean, it is, and the burden of staffing, I think their number one job, 24/7 responsibility. We can see that they say they are not, or not at all, you know, a large portion are not emotionally healthy. So we at AONL, we are working specifically on this group of nurse leaders. Also, we see the statistics around physicians. Lots in the literature about burnout. We are also, AONL, NHA, working very closely with the Lorna Breen Foundation. There's lots of well-being initiatives that are underway, also with the National Academy of Medicine, but, you know, very, very alarming numbers. Our travel nurses, we've seen an increase, you know, prior to the pandemic, and I've been around a long time in nursing and, you know, staffing, 7% was the usual number we would see, and travel nurses have a great place, you know, to help us with our fluctuations. So in my role as nurse exec in Atlantic City, we would see our census pop every summer. It was predictable, all the shore visitors, and that was also the time when my staff wanted to take vacations because they live at the shore. So we would engage travelers every summer. They would love it. We knew them. They'd come. They'd supplement our staff, and, you know, we budgeted for it. It was wonderful. You know, great relationship with our travelers. So, you know, you have vacancies that, you know, a long-term medical leave, for example, you bring people in. I mean, I absolutely support the appropriate use of travel and, you know, travel nurse and contract labor. However, you know, what we saw during the pandemic is that, you know, we had dramatic swings in nurses who would leave one hospital in a big city and go work across the street for, you know, very significant increases in compensation. And we've seen a little bit of right sizing, and here I'll put the next slide up because that also addresses the cost. We've seen some right sizing, but I can tell you, particularly in the procedural areas, and you may all see this in the ORs, and I'd love to know by a show of hands how many has seen it stabilize, the travel nurses in your ORs. Anybody want to say yay, nay? A little bit? And how many still see tons of travel nurses? Yeah, okay. That seems to be the trend. The procedural areas, the EDs, in some areas and regions of the country, the ICUs, and there are still hospitals that have significant amounts of travel nurses throughout. I think cost is a real concern, but there's also the issue of teamwork and how many, you know, if you're looking at your cadre of nurses and your team members on your floor, what's the appropriate number? You know, is there an impact on safe care? I mean, things like that are all things that are being studied. I think the jury's really out there, but boy, it really, you know, I heard from a lot of staff nurses that were very concerned that the person who they're working next to is making 3 times what they are. And by the way, they sleep in their own beds at night because they only live, you know, 45 minutes away. So sometimes really a real concern, you know, from an equity perspective. So also know we see some contingent labor in other areas, not just staff nursing, but also, you know, you name the profession, we see an increase in that across the board. So future healthcare workforce needs. If we look at these numbers, we know that alternative care settings is expected to rise in the next decade. Inpatient care, though, is also expected to rise moderately, not the rate that we're seeing in outpatient and alternative care settings, but still more settings means more people that need to take care of the folks there. Also, we are expecting to see a bump in the emergency department initially, and then, as this one study suggests, it levels off by 2032. Now, time will tell. We'll see. Some of that has to do with reimbursement. What our, as Lee said yesterday, if Medicare Advantage becomes the only way to access there's lots of accountability that health plans may need to take, and they may drive our patients to different settings. But we'll see. But what we need to do as healthcare leaders is really focus on what we're going to need for the future as well as what we need for now. So one great example that I never even thought was a skill set that we would need in the hospital 15 years ago was cybersecurity experts. And when my CIO used to talk to me about cybersecurity and the fact that they're contracting out and it's something to worry about, but it was very very nebulous. I mean, now I think from what we're seeing around the country, hospitals are finding that they need to employ people who specialize in things like cybersecurity. So, I mean, who knows what the future holds? Technology, will also mean that people need to support some of the new technology. It's not just all about, platforms and gadgets and new toys. So, some key areas that we know now that, and what we're focusing on are, the interdisciplinary team. Heard that all day yesterday as well. It's not just about your profession or your discipline. It really is about the care that we need to deliver together. Leadership competencies that we probably, if we really look in the mirror, don't have right now. So change, not just change management, but change leadership, innovation. I'm going to talk a little bit about my own perceptions, but of yesterday. But I think the aha to me was that, in sitting at the table and making decisions about huge purchases, and not feeling in the past like I've had the ability to make the right calls. People are really gun shy about investing millions and millions of dollars, making decisions that will impact the care for the next, decade or more in their organizations without the appropriate skills and competencies. So we really need to look at what our leaders need for the future. Technology is a tool. I think we mentioned that earlier, and there's really no topic that we can talk about, whether it's practice, education, et cetera, where technology isn't an underpinning. So, education and practice really need to partner together. I know we have some wonderful examples of that across the country, but we also have community colleges in places that really have very little access to, to technology that we need for education. And, we're not islands. We really need to pull in community-based, education organizations, rather. We talked about social determinants. Now we like to call them social drivers of health, but those things that we consider social services, in Europe and in countries across the world, that really is lumped into, the healthcare spend. So I think it's a little false sometimes when we compare our spend to those, other countries across the world, because many times they lump in their social services with healthcare, just saying. In the parking lot really is, the boards of nursing, the boards of medicine, the boards of every health profession, and how we really are siloed. And we're in protectionist mode. And is that really what's going to get us, where we need to be in the future? So real quick, I'm just going to buzz through some of the work that we're doing. Workforce is an important strategic framework for AHA. You can see here we have a now, near, and far focus. The way we've organized our work is that, we have initiatives underway that we want to have immediate impact, but also work underway that we know will take longer to actually bear fruit. And AONL and AHA are working very closely together. We have a board-led workforce group for both organizations, and they're cross-pollinated, and we're trying to do everything as integrated as we can. So here are our key focus areas for this year: culture of work, care model exploration, workforce planning, and messaging the healthcare career. And I just want to say a little bit about, we are inventorying the models of care that we saw spring up throughout the pandemic and post-pandemic. Most have a team-based element. They're interprofessional. The role of the virtual caregiver, i.e. virtual nurse, is, I would say, is usually included in most of these new models. The term virtual nursing, by the way, it's the Wild West. We are working, AONL, with ANA and other nursing groups to really define scope and standards for it, because, you know, we've talked where virtual nursing doesn't even have any nurses that are involved with it in some, you know, according to some folks, whereas, you know, on the other end of the spectrum, I think we also see, you know, nurses being used for just observation, which is really, in my opinion, you know, not utilizing them to their full scope. So we are evaluating with IHI through a grant from Johnson & Johnson, successful, scalable models of innovative care delivery. We are focusing initially on inpatient models, but we really see that needs to expand. There's some excellent hospital at home models as well that are part of the inventory. And I mean, there's so much work going on here. The challenge is being able to critically evaluate them all and to actually just share the information. We have so many people working, you know, on things, and they're head down and they're not able to share. We are convening a summit with technology leaders in nursing next month, actually this month, September 19th. And we're collaborating on, as I mentioned, scope, standards, and competencies for virtual nursing. And what is the impact of AI? What technology can actually help reduce the workload, not just for our frontline nurses, but also for our nurse leaders. So that's just a little snippet of what we're doing there. Here, the next several slides just has more detail around those, you know, those areas that I mentioned. And, you know, one thing I just wanted to point out, as we look at hospital at home, it really became apparent to us too that here under, well, I guess it would really be under care model exploration, that we found that the issue of equity really did come up. You know, some homes were not safe for the patients, let alone the staff, to go and provide, you know, care at home. And so it sort of raised a question about, you know, we really do need to look at equity for our patients as, you know, they are being provided with care in the home. And, you know, we saw large demonstration projects for hospital at home, and we also saw some small ones. So that's work that's being evaluated as well. What I wanted to say about workforce planning is we have to plan for the future. Messaging the health career is important. When you do the research, kids in high school, if you're trying to talk to juniors and seniors in high school about a healthcare career, it's really kind of too late in many cases. We really need to start with the 7th and 8th graders. So some of the programs that we have seen success with across the country is getting to those younger kids, exposing them, you know, not just one day a year to come to the healthcare setting, but really to make it a more programmatic where they can really see what a career in healthcare is. And it doesn't have to be just, you know, clinicians or people touching patients. It really can also be, you know, what role IT has in the healthcare setting, or, you know, a number of other functions. So a little commercial here for AONL. We got nurse leaders from all over the country to participate on these different teams, and we have a great document that's available, and this is not just for members only, this is available for everyone. So if you want to, you know, to direct any of your team to our compendium, we would really, you know, I'd be happy to provide more information. What AONL specifically is working on this year is the role of the frontline nurse manager. We're working on the care model inventory, as well as, you know, our project with IHI, and also pulling together the technology that will be helpful to our nurse leaders. So I know I talked really fast, but here's just a couple observations that I had from yesterday. So, and this is my last slide. I think we all know leaders, healthcare leaders, nursing leaders across the country know that healthcare in 2030 and beyond is going to look very different than it does today. But how do we get there from here, I think, is the big burning question. Our nursing leaders in particular, and I think most of our healthcare leaders, are working on head down on the operational issues. They are working on shortages in the workforce, the challenges with resources, with burnout, with workplace violence, with supply chain issues. And really the role of leadership is to be strategic and to really be able to look towards the future. Could I have my slide back, please? So I have, my notes. I think also the baby boomer issue is really a double whammy and something that we really have to prepare for because it's really impacting supply and demand. We are, I consider this group to really be thought leaders and to be, for the most part, coming from organizations that really do have resources that are able to support, innovative and creative roles. Not that everybody doesn't have financial challenges, but when we look at those other places that I mentioned, the rurals, the critical access hospitals, many of the standalone community hospitals, they're just almost paralyzed. They're, really concerned with the future, but they are immersed in the day-to-day. So, I challenge the thought leaders in the room to really not forget about, and to offer some guidance towards those other organizations because it's, it could be a different world than from where you spend your, the bulk of your career. I hope you see how privileged you really are, and I hope you're not offended by that. Generational differences, they're hit, it's obvious in our healthcare workforce, but it's also, obvious that our patients, we're taking care of, multi-generation society and, a very diverse society. And we have that has lots of implications for us. I didn't get a chance to talk about it. I'm proud to say that I was really committed to, to my, in Atlantic City, to my schools in the 1990s, where I was able to offer, through my healthcare organization, scholarships and fellowships to kids in high school that probably never would have been even able to attend, a associate degree school. They were able to become nurses. And, I still hear from them, and they've gone on, and some have advanced degrees. And I think we really have to, realize, as was mentioned yesterday, that it's a business decision. The ROI for inclusivity, diversity, and equity is there. It's very clear. So we really need to focus on that. I mentioned earlier, tech is really expensive, and leaders are so worried about not spending money appropriately. And so we really have to help them. When I think about the last iPhone I bought, it was right before the new one came out. I was so mad because, if I would have waited 4 months, the new one came out and I would have had the last bells, the latest bells and whistles. And I think that that's just like one little example, but everybody wants the best, and, it's costly. Yesterday, and I'm going to do a lot more research on that, I so appreciated Megan's a presentation around implementation science, because we have really been focusing on evidence-based practice and evidence and evidence and evidence and evidence, and we really haven't thought as much about the components of implementation science that really might be the key to us adapting in a much more rapid fashion the things we need to get done. So, some of the things she talked about, target strategy to the context, bring all stakeholders to the table. Incentives may be different for different groups, but that's okay. Technology must be implementable. workflow is paramount. That's why we can't get the front line to go along with what we are choosing, is because we didn't pull them in early enough, and we're making choices for them that's going to affect their everyday life. We've got it all wrong if we don't think that they're important on the front end. I mentioned change leadership and innovation competencies. And I think my last thought was that we so need to reduce the burden of our caregivers as rapidly as we can. Speed is of the essence. If we lose more nurses, if we lose more physicians, frontline folks, it's just going to make it worse for the folks that are there. And then I think it's just a vicious cycle of who wants to be the last man standing or the last person standing. So I am not a pessimist. I'm going to end by telling you that my job, for the past almost 5 years, I've been traveling the country probably 60% of my time, with the exception of COVID when it was Zoom and Teams calls. And I have talked to so many young, eager, intelligent nurses, physicians, healthcare workers, and I have real hope for the future. My daughter I'm very proud of her. She's a trauma nurse practitioner. She loves her work. She always gives me the reality. I'll say, I'll complain about the younger generation, and she'll say, Mom, and I'll hear the reality of what she's doing every day. And it's hard work. We all know that, but it really, speaking to our millennials, our X's, and, our Y's, you name the alphabet soup. I think our future's in good hands in healthcare, but we just really need to realize that speed is of the essence here, and we got to fix the workforce problem. And so hopefully you will all join with me to commit to paying attention to this, because it's really important. So that's all I have to say. I'm going to hand this back, and I guess we go to panel? Yes. Thank you, Ken.
Thanks so much. I'll invite the other panelists up. I really appreciate that you ended on a note of optimism. That was great, even despite all the statistics. As we get the panelists up here, I am cognizant of how we spend these last precious minutes that we have together before everybody leaves. So we're going to have some discussion. If it starts to peter out for whatever reason a little bit, we're going to do a quick break, I think, get everybody to the bathroom, some refreshment. My plan will be to do that for about 10 minutes. We'll reconvene. Maybe we finish a little bit early, but definitely by 11:30, we'll get everybody out of here. So, questions for the panel?
I have a question.
It's to you guys. Yep. Okay.
Over here.
All right. Yeah.
Hi.
Please go.
So I think mine are wrapped around the idea of tipping point. And so, first of all, thank you for your presentations. For Julian, one of my questions is, as I think about the use of your remote device, if I just kind of globally say that, one of its potential opportunities for use is in our post-acute care settings, where we have long-term care areas where we do need ventilated patients, but we have institutions or organizations who are not willing to put in that resource, or they don't have the skill set to be able to feel comfortable using the ventilators. But that's a very low, poorly resourced area. So how do you get, have you thought about either that as a use case, or philosophically thinking about how do you get to a tipping point when one of the biggest potential opportunities is a poorly resourced area for its use? And then connecting to that, the tipping point to Mike and Robyn, and I don't know if Subha's still here, but I was thinking about a resident being trained on Caroline and your remote ICU and getting very, very comfortable with the whole social technological interface and feeling like their whole workflow is changed. And now they're an attending, but they've come to Honolulu to practice. And we don't have those things. And so how do we guard against the potential safety implications of, while we're still trying to get to that tipping point, people who get trained in these great new ways of doing things, but then find themselves suddenly in a place where that's not around again, whether you've had experience or had thoughts about it. So they're kind of both relating to us moving ourselves up to a tipping point of adoption.
So that's a superb question and excellent points. So thinking about remote control, the idea of remote control as a need is not new. I mean, as anesthesiologists, we have been talking about this for years. Why in the world do we have to turn off an anesthesia ventilator and leave an interventional radiology room, run outside, wait for imaging to be over? Why do we have to turn off a ventilator in an OR for an intraoperative cholangiogram and then go back in? There are reports of patient deaths because people forgot to turn ventilators back on. So, we've been thinking about this for a long time, but frankly, there wasn't enough activation energy to overcome all the barriers. Manufacturers hear those requests, but they have to think, oh Lord, now we're going to have new liability. The FDA won't let us do that, et cetera, et cetera. So the need has been there for such a long time. It's also there in other settings, for example, pausing ventilation for MRIs or other imaging, and on and on. So and adjusting infusion pumps. And then there are patients in the ICU who are either on isolation or reverse isolation. We already know those patients get poorer care because the activities are batched by the caregivers because of the time it takes to do that. So there's always been this percolating need, and that's been going on for a long time in kind of the technology community and in some of these areas. But in this case, frankly, we're not wasting a crisis. So Ebola let us make a rapid advance in just a few weeks, which educated everyone, engaged the FDA, demonstrated their support, and then it kind of put things on hold for a while. But kudos to Nihon Kohden for going forward and getting moving a product through the regulatory process just prior to COVID. But if we talk about the range of applications, fully agree. There could be areas in where you consult with far remote expert caregivers that have to fine-tune ventilator settings, whereas other folks who are much more comfortable with making basic settings, and that's often nurses caring for patients. Sometimes it's residents that are doing that. But highly skilled respiratory therapists and intensivists who really know how to optimize ventilation may not be available. And then, of course, the DoD was especially concerned about a use case in which unskilled people have to put a patient on a ventilator. Maybe a more skilled person performs an intubation and sets the ventilator, but then they have to move on. And now we're dealing with lower skill levels or troubleshooting. Now, I'll finish with this thought that we focused on what we discussed in terms of the pandemic, but we already saw, for example, at Mass General that the remote control capability has already been moved into the imaging environment. So a respiratory therapist could pause the ventilator or make changes during imaging. So once you hand people these capabilities, and Medtronic has reported that back to me as well, where they're seeing wide interest in adoption, and they've publicly messaged and discussed this in our standards committee that they are filing for regulatory approval for a product that will now meet not just emergency type of use for the immediate in effect guidance, but for widespread use where it's needed. So we're trying to basically leverage the opportunity to introduce technology and capabilities that we should have had a long time ago. And that's the way life works. We're not wasting a crisis. I think that, so in every area you mentioned, completely agree with all these different use cases. So passing it along, what was the other question for? Oh, I think your mic works.
Okay. Mine works as well. I'm good. The only other thing I would add is that I think that, I agree, we can't waste a crisis. And the other thing is if having this kind of support becomes the standard, we need to also do some advocacy about getting funding for things like, like this.
Whether it's the post-acute facilities can't afford. I mean, it's not in their budget at all. It's not even going to get any.
All right, let's.
Can I comment?
Did it ever go down suddenly for a day? And how did you?
Well, could I go to a high level? I think it's all about standardization. So coming from Europe and having worked in Australia, you can see that how national health systems work effectively. And you can go from hospital to hospital and you don't have to reinvent the wheel. We've got a pilot who works for Southwest Airlines. He can go to American and still fly the same plane. And yet we just move down the road here in hospitals, even within health systems, and you've got a different interface. And it all adds to the burnout. And what's a shame is that we can't all agree on standardization. We know, like, say, I'm just taking an example that you brought up with Caroline. We know that works. It interfaces with almost every EMR out there. If you made that an industry standard across the USA, we could tackle the staffing and burnout process. But the problem is competition doesn't allow that.
I think there's another nuance to it where as we started to move and prototype and to study a single integrated interface, one interface to control multiple brands of infusion pumps and multiple ventilator brands, there are certain kind of minimal or basic functions that are not difficult to standardize, changing the rate, changing a tidal volume. But then there are the nuances that may depend on the specific ventilator and its unique capabilities or some things like that. So we have to thoughtfully consider how do we enable innovation, just as we do in consumer electronics and elsewhere, while ensuring that basic controls like, you know, where the brake pedal and which way you turn a steering wheel and so forth are standardized and common. And we need to get there, and we just have to consider both, where there's always room for innovation. So both are true and sorely needed.
Jim Suchik, University of Michigan. So I've got a series of observations, a few hypotheses, and then I'd like the panel's input on how to implement these hypotheses if we feel they're valid. Observation number one, it's impossible to build a team with the high turnover that we're having as a result of the burnout. There is a huge divide between management and the worker, especially on the nursing side. Our nurse managers do no direct clinical care and enforce rules that they don't have to live by, and the low-level RNs in our recovery unit are the ones that have to do all the documentation and that. And our IT people make decisions on the EHR without very much input from the end users there. So we're in this point where during the pandemic, we were in survival mode. We're just putting Band-Aids on things, limping by. And what I'm seeing now is that there's a scarcity mentality that we're still going, where competition is bad. It makes the pie smaller. People are not focusing on abundance and making a bigger pie. People are always focusing on the limitations, not on the opportunities. We're thinking small and fearing the risk rather than thinking big and embracing the risk. Not so much at this meeting, or that we're focused on cost control. We're not looking at investments with a big return. We're not looking to create win-win situations. It's all about looking good and fearing outcomes rather than embracing them. So how do we get, the solution for one is skin in the game. So no one in IT should be making an end decision without having the end users at the table. No one in nursing should be putting forth a directive without having to live by the rules of the directive. No CEO, CFO, administrators in a healthcare system should be able to go outside of the system they're working in to get their healthcare. They should really be invested in the system there. So that's the skin in the game. And then the other is just changing that mindset to one of abundance rather than scarcity. And that's a huge, huge shift to say, you know, we're going to take risks. We know we may not get the right tech now. We're going to have some redundancy there, and we've got the resilience and the abundance to do that.
Wow. Well, great observations and agree with all of them. I think the challenge from the first thing you mentioned was about teamwork and how hard it is to build a team. Agree. And, we know that the gig worker or the younger generation does not expect to be staying in one place the way people of our generation have spent their career. So if we look at things like the airline industry, as you mentioned earlier, a pilot can go and, and flight attendants can go from airline to airline, and they can be part of a team because the work is consistent. There are standards. So that might be one component of a team. Maybe it's teaming, it's not the team. The second thing is, from a nurse manager perspective, they need to be one with their staff. And what you described is not really what I'm seeing at across the country. So I don't know if it's particular to your organization. And that's some of the work that we are doing at AONL around the nurse manager role. But thanks for that feedback.
Yeah, I'm such a broad subject. I think you've got to look at the health system and the CEO and what the goals are of that health system. And then you've got to look at the governance to drive it all, because without the governance, you can't affect any of the changes that you're talking about, and you can't engage people in the way that you talked about. I disagree about the building teams. It all depends on individuals and the managers and how you're trained. Being heavily involved in COVID, in the first wave, which was the really bad, I think, bit of COVID, we actually had the lowest call-out rate that we'd ever had because we set the team up, we trained everyone, we got everyone feeling that they were committed to this together, despite the inherent dangers. So there are ways to do it, and it all boils down to individuals and leadership, I think. So it's all about appointing the right people into the right position in your health system.
And I'd say that there have been a few silver linings in COVID, as we know. One of them is that we found that the creation of interdisciplinary teams that cross the entire system, there was the impetus to do that. There was the willingness to do that, and volunteerism, and a number of those initiatives have sustained themselves because people found that's the best way to get work done. And we've always known that to be true, but again, we needed a reason to do it, and we needed to overcome typical barriers. I think many of us are really gratified at how much more effective we can be and proactive we can be.
All right, so terrific panel. I think we will stop here, take a quick break. Let's spend 10 minutes refreshing, and then we'll reconvene for a recap and some discussion. Look forward to your comments. I'm going to ask everybody to start to reconvene if you can, and we'll just talk a little bit longer. Come on in and have a seat. Anybody else want to sit down and chat for a few minutes? I don't have a really big agenda for the next few minutes, and we can do this for as little as long as you'd like. I am looking for feedback from people. I've heard generally good comments, but if anybody wants to share what they've learned, I was struck by the earlier answer to the poll about industry needing help with education. And if any, and something like webinars is not something that APSF has done much, if any, of, but certainly something that we could think about organizing. So people wanted to share some thoughts about the effectiveness of that forum or the need for it. I'd be interested. But what, any thoughts after the last couple of days? What have you learned? What are you taking away? Things that you think will inform what you do? Anybody? Comments? Questions? Are we done? We use everybody up? Tim?
Tim Dowd from Northwell Anesthesia. The thing that I was struck by, I've been, more recently working in a lot of different locations and working with a lot of different healthcare systems and actually giving anesthesia a lot. And what Mike Scott presented for the way an ICU is designed and run is that for me was, Scotty, it's Star Trek. This is perfect. You should almost retire and say that it's just can't get any better than that. But the typical electronic medical record system, forget interoperability. There's none. I'm working in a system now. It's a Northwell system. There's a private practice group with a health record that doesn't interact with the hospital's health record. The health record is an old health record. designed to be replaced that doesn't work particularly well. There's no consistency across it. And you still have to sell to doctors that an electronic health record is an advance. Because in a lot of ways, the way we're using it currently and where I'm working, the electronic health record system is not an advance. There was a great discussion of, to-do lists. One of the things that doesn't happen in a lot of electronic medical records is there's no to-done list. So things, once they appear in the record, never disappear. So I will do a preoperative evaluation of a patient where I'm looking at a healthcare record, which was all done with checkboxes that never expire in the health record. And so they're talking about the patient's antibiotics for an infected knee, that when the patient actually presents for his endoscopy, that infected knee was 14 years ago, and it's still in the record as an active problem. So what I think was magnificent about this is there are, cities on the hill where electronics makes a huge difference, and it's, just where can I get that? The problem is, for most people, most of the doctors that are practicing medicine in the United States right now, the answer is you can't. And that's a problem. And I think we really need to talk about how we get from here to there. That was, what was it?
Robyn.
Robyn, yeah, who said that. I thought that's really an issue. And we need to talk more about that. We didn't really hit it during this meeting today.
Thank you. Great comments. Yep. Warren.
Jeff, I don't see anybody at the other mic, so I'm just going to go out of turn. So as I look around the room, the people I see here are some invited keynote speakers, some folks from various regulatory or professional associations, and then a group of senior academic physicians who work at the few academic medical centers that have enough resources to allow us to travel still, given the huge labor shortage that we're facing. And it's a very rarefied audience. And to the comment that just happened, this went by, I think that we risk producing something that is just not relevant or accessible to 95% of the physicians working in America if we don't acknowledge that most of the people in this room either have a limited practice because we're older, or we're working in very resource wealthy departments that are still doing well enough to let people travel and travel professionally, not travel as nurses. So we just need to be aware of that. I think it's a big challenge. We need to be careful to produce something that's relevant.
So great points. We do have people from industry here who sell into the broader market, not just academic medical centers. So
sorry, I forgot to mention that. Yes, many wonderful participants from industry as well, but they don't have the same labor problems that we do.
Yeah, yeah. But I'm wondering if there's any comments from anyone from industry about, reaching out to those markets where they are a lot less resource heavy, but tremendous opportunities to impact patient care. Any comments on that? Challenges to reaching those markets, making technology proliferate? Too loaded a question?
This was a question I did ask Nirav yesterday about MPOG and the types of institutions they're engaged with that are actually going to be benefiting from some of these analytic tools and in these process and quality indicators. So even with the United States, there's a tremendous disparity in the resources that exist at the healthcare level, healthcare system level, and then at the individual hospital level. So as a med tech manufacturer, we have to understand that tremendous heterogeneity that even exists in the United States. And we can't expect that one technology is that's going to work great for Warren at Vanderbilt is going to be working for Dr. Canales' facility in Los Angeles. So there's a lot of heterogeneity there, and I think that came through this week.
Yeah, I think one interesting thing about what we saw from Caroline and the Tele ICU at Penn is that those are built on top of the existing EMR because the EMR can't do those functions. By the same token, the tremendous growth of EMRs has given us data repositories with the ability to build on those types of systems on top of it, with lots of questions about the quality of the data. So it's like a lot of things, a double-edged sword. We have built this incredible data source out of the EMR. We don't have a good user interface for dealing with it, but it has created the potential to actually do some interesting things on top of it that we're obviously seeing now. But Warren, did you have a follow-up comment?
Yeah, actually, I was really heartened by Mike's presentation about the Tele ICU at Penn, because it was actually built on Epic. So we don't need to go to a standalone vendor. And as much as I don't really appreciate having essentially a monopoly making EMRs now, since Cerner is kind of a second tier system now, it's good that we can at least use Epic to do that kind of stuff. I mean, Bell Telephone, when it was a monopoly, did connect, most of the country, and eventually got broken up. Maybe that'll happen to Epic someday. But I mean, the application suite in Epic is now becoming usable. You can see the potential now, where half a decade ago, maybe not.
I do actually have a question for Mike. I don't know if he's still here. Are you still here, Mike? Mike, yeah. So I did want to ask you a question, and I'll just use this opportunity since I have the mic and no one else is standing there. But I'm curious, clear that the workforce issues are probably the most burning platform right now. If we lose providers, doesn't matter what kind of tech we put there. What's been your experience with the Tele ICU as a retention and recruitment tool for ICU nurses, where we know there's a high level of burnout? Do you think that some of those nurses who have been thinking about leaving maybe are getting more engaged, maybe not likely to leave? Do you see new nurses wanting to work there? Is it a retention or recruitment strategy, that kind of technology, in addition to the teamwork stuff you've built?
I can't really give any facts on that. I think what it does do is it offers bedside support, so no one feels alone at night when numbers are down or if they can't escalate. I think what I'd like to do is use this model in a completely different way, because you can actually run your whole health system and actually push your APPs and your MDs where the patients need it. If the patients are on an ERAS pathway and they're not needing much intervention, you can just push them along and focus on the patients that are not progressing or deteriorating. So it could actually completely change how we affect our resources, because you've got this two-way communication and audio-visual, and all our patients basically consent to have care by the Tele ICU team. So we are a named provider on the charts. So it does open, there's just a new way of how do we actually resource allocate. Because if you can do all these things remotely, like our ERT can round on 400 patients using that dashboard. Because if everything is okay, then nothing needs fixing. You go on to the next one. So all the vent checks and everything, all that routine work has just now been taken away from the bedside RTs to actually do interventional work. So I think it gets to the point is we've all got to think outside the box, haven't we? And if we just redesigned with what we've got as new tools, how would we actually build our surgical teams and our medical teams, and how would we deliver care? Do we really need people in teams if we actually had something like Caroline where everyone can talk to each other and know what that patient needs every day? I do think we've overcomplicated it with the EMR. I think back to my days in the UK where we would just round and pull all the lines and tubes out and give the patient breakfast and get them on their way. And we'd do that on the round, and it was done. Whereas now there's all this discussion, there's an order set, you go back at 12 o'clock, we've still got the Foley catheter in. And so I think we've got to rethink it. There is burnout, and there is this terrible interruption. I'm really adamant when I round that there are no interruptions. And I basically have one phone where any incoming noise comes and it gets taken away from the round, because you round more efficiently. And the problem is we've got so much noise, we're becoming less and less efficient. I mean, the nurse knows we're going to be 2 doors down because that's how we're rounding, and yet they'll still come and ask us things. So you've got to manage all this expectation, and we've got a different generation who have grown up with iPhones and used to getting instantaneous replies. I think one of the best things about the care line system that we use at Penn is the fact that you can park all the things. So they know we are coming and we don't need to reply. So it's like a watch list and a waiting list. So we just got to reinvent how we work, I think.
Do you have trouble filling any of the shifts in the Tele ICU, the command center with providers?
So the RNs we have a fixed, they only do Tele ICU. The APPs, because we wanted to create that relationship with the bedside provider, our head APP allowed us to recruit from all the different APPs, you know, whether it's cardiac, surgery, neuro, medicine, and they rotate through there. Although we are aiming to actually have a more core group of APPs, so 2 or 3 that are more centered there, but people still rotate through. Because if not, one of the biggest barriers is all to do with this safe environment. People think they're being watched and judged. And that's one of the biggest problems when we rolled out to a new hospital, is trying to get the buy-in of everyone bedside to make them realize that this is just quality improvement and we're there to support them. We're not spying on them and putting safety nets in. So that was key. The MDs, again, I have someone who works 50% and then we rotate through all the specialties. So we try and make sure that all the hospitals are represented, and that's the way we've moved and grown the system so rapidly.
Great. Other comments, Warren? You want to follow up some more?
Yeah, you just asked a question about whether some of the assistive technologies like an EICU would be useful for retention. And it's too early to make a formal comment about it, but we just turned on a virtual nursing pilot at BUMC, and we were able to spread one nurse over many projects that would require a lot of bedside nursing time, but don't need to be hands-on. So the duty cycle for the nurse in the command center is such that they can cover 2 30-bed units as the second nurse in the virtual nursing component. Patients love it. The nurses on the floor really love it because anything that requires dual sign-off, they can have it almost instantly instead of having to go track down a physical person. So early reports in the first 3 months of implementation is that virtual nurses love it, patients love it, and the nurses on the floor love it. So there's no, and we've actually seen an impact on the fraction of patients discharged before 11, which is a key metric for us to move patients out of the ED. And consequently, our length of stay is down a little bit. And I think that's going to be the payback right there, is the reduction in length of stay.
And we're building a hospitalist system looking at e-pharmacy, because it's all about taking the pressure off those bedside providers. It's like the APP has got 5 admissions at one of our peripheral hospitals at night. They can put 2 under watch, DKA watch and something else, you know, hemoglobin watch, and they know then they can focus on the other 3. And that's all how you reduce burnout. You're sharing the load, especially at nights and weekends when people feel very alone, I think.
Anyone else? Parting comments, thoughts? I don't know. Where's Dan? Dan, do you, Dan Cole? Maybe we lose Dan too? Okay. Anyway, so Sam, please.
It's a quick comment. We never considered, I think, at this meeting, the patient as helping with staffing. And we did a study way back where in our PACU, where the patient was asked every 2 minutes to pinch the pulse oximeter probe, and then the signal would go away. And then we would know the patient was awake and not unconscious. So that's something that, because you could argue that to ask a nurse to say, hey, are you awake? And it's not highly skilled nursing work. So to the extent technology can get the patient in the loop of taking care of themselves, especially when they go home, that's an aspect to consider.
Yeah, great point. And APSF has a patient outreach initiative that we've been building on over the last year. Steve.
Yeah, thanks. Julian is still here, so I'm going to ask a question that's related to his talk. I'm always intrigued and excited when our new developments in our field remind me of old science fiction stories. And I was reminded yet again this morning of iRobot. Read the book if you haven't. So Julian, if we allow remote access and control of ventilators. And, the next step would be, oh, well, why not infusion pumps and stuff like that? How do we 100% guarantee against hackers? They're very clever. Passwords don't always protect. I'd be worried about the dark side, the sinister side, the central computer basically taken over. Paranoid, but.
I think you have trust issues.
Well, that's the problem.
Don't worry about it. So I think, first of all, our healthcare system is greatly exposed today when it comes to cybersecurity. And adding capabilities that we know can improve patient care and patient safety, like remote control in many environments, done appropriately, doesn't change the fact that we have a much larger problem. And because we have a larger problem, it's concerning a lot of people in our government as well as other governments in terms of major changes that are needed in how medical devices are manufactured, maintained, and connected. You know how hard it is to update a medical device with its embedded operating system, unlike a computer that you can push a patch or an update. So yes, you increase, what is called the attack surface when you take a device and extend it. Now, I kind of spent a fair bit of time showing the details and the standards of the safety aspects. One of the key concepts is that we want to ensure that by adding remote control, we do not undermine the basic safety of a connected device. So those kind of firewall has to be built into the device, so it can't become an entry point to cause harm in any other way. But can someone, can a hacker get in and then control that device? In theory, that would be true, absolutely. And so we have to be thoughtful about where that is appropriate, where it makes sense, and how it has to be hardened. So in the examples so far that we're seeing in the market, some of those examples involve using a dedicated connection, a wire. And that's true. I didn't mention in the presentation, but a Thornhill company has a ventilator that also has a wired connection for use in military transport or other emergency transport. Once you hop on the internet and do these things, you have to address it differently. But there's a whole also range now of emerging technologies to harden systems like that with greater security. And I would not treat it with indifference. I think you're right. But we also should balance it with the fact that there are limitations of care that we've hit, all of us, and there are reports of deaths and injuries from turning off ventilators. We struggle. So there are ways of doing it and maybe not passing the boundaries of a hospital network, for example. So we have to be cognizant of that. I fully agree.
Good. I mean, we just need to keep in mind when we create new systems, and remote control is asking for it.
Right. So by the way, we connected, there's technology now that's becoming more adopted called software-defined networking, in which you can allow essentially a secure connection between different sites. It's becoming more commonplace, and that's what we used for some of these demonstrations. It was actually a secure connection. I also did not present, but it's online, the software, the security analysis that MITRE performed using what they call STRIDE, and anyone could look up MITRE, STRIDE. They performed that analysis of the system. So there was much more work that was done on security. I didn't think there was the time or, to really get into depth, but I'm glad you raised it.
Thanks.
Thank you.
Can I riff on that?
Please.
I think that in terms of where APSF ought to go with this topic, and we as society ought to go, is in this space: safety, privacy, de-skilling, or backup, human in the loop where the human's not really in the loop, centralization of control of both the data and the activations, these are real risks, and I agree with Steve that the hackers spend a lot more time thinking about how to break the system than we're spending how to protect it, right? And so as we centralize our data, as we create monopolies in healthcare, as Warren alluded to with Epic, and as we heard yesterday that Epic's using their data in inappropriate ways, data that we didn't necessarily know they had access to, or at least that they would be doing that. That this is a topic of great importance, not just in healthcare, it's whether you're talking about automated driving. What we learned early on in medication prescribing in pharmacies is when you have computers control it and it's centralized, one little software bug can lead to tens of thousands of patients getting sent the wrong medication in the right labeled bottle. And as well, that was a Kaiser example for some years ago. So I really think this is a critical topic, and you know, AI has only raised the bar and has actually gotten some people's attention. But this is an area APSF. It's a safety issue, obviously.
Well, okay, but I would push back to say, let's not frame this as a new safety issue and a safety risk, because let's think about the fact that there are implementations and products that could be implemented that have minimal to no potential additional risks. For example, do you worry about someone hacking your TV remote control that's using IR in your house? Not really. If they did, yes, they could change the channel, and if that was a ventilator, you'd be worried about it. Now, a remote control could be a unit in the ICU attached to the wall right outside the room that is connected and designated to connect only to those patients' devices in the room. And it could be hardwired, so you don't have to run into the room each time to change an infusion pump setting. So you could respond faster when delivering care, respond to an issue, not expose the patient who's in reverse isolation. So how it's implemented matters greatly, right? Versus thinking that it's going to be over your phone while you're, you know, whatever, on the golf course. Or, so let's not just, I'm just saying, let's not paint everything with one broad stroke that all remote control is the same, because it isn't. And some of it might be such high risk that we think it's not a reasonable thing to do and it's not safe.
I'm a huge proponent of remote control and of AI and of all these things.
You gave an opportunity to tease it out, so I wanted to tease it out.
Right, and implementation matters. As a human factors engineer,
Exactly.
I'm the first one to tell you that what you're going to need for whatever we're building is be different than what Steve needs, which will be different than what Jeff needs. And if we don't account for that in a safety critical situation, that's a problem.
Absolutely.
What I'm saying is more about the quote, who's now I've forgotten the name from yesterday, about how, you know, we're much better at building technology than we are at building the social and ethical and other infrastructure to make sure that we do that wisely. And especially in America, which is so financially motivated, and not to disparage industry, because I consult for industry, but industry, both the device industry, the software industry, and our healthcare delivery industry are all profit motivated, even if they're nonprofit. And we have to have other structures in place, and APSF is can play part of that role to make sure that it isn't all about the money.
Yep. And I think to underscore that, as we know in anesthesia, it's all about vigilance. And what you're, you know, promoting now, and I fully concur, is we all need to be vigilant that we don't reduce safety overall while we strive to leverage technology to improve it. So we have to be vigilant. We have to be on top of this.
Okay. Anybody else? Any other comments? If not, I'm going to pass the microphone to Dan Cole to conclude the meeting. Thank you all again.
Well, thank you. And I think 3 points here. One is to thank Jeff, the planning committee, and all the speakers for a great presentation. We give them another round of applause. I know for me, and I would consider myself maybe in the top 10% of people within the perioperative space that understand this, but this has been like the first day of gross anatomy in medical school, where I figured out, you know, I'm really probably down in the bottom 1 percentile. And so it's kind of filled me with a lot of knowledge, a lot of questions, but there's a little bit of a gap here, and we always try to develop some recommendations or a path forward. And so we've got a lot of questions, a lot of things that have been put on the table. So I think what we're going to try and do is develop a task force that can meet after the meeting and develop some APSF recommendations about a path forward in the perioperative space. They'll be very broad, as they should be, but again, we want to accelerate that performance curve. And with that, I just want to give another quick reminder. Next year, Boston, same time, Wednesday, Thursday, after Labor Day, on medication errors and opiate safety. And with that, thank you all for attending.
And you
want the last word.
Well, I just want to emphasize that there has been some discussion about doing something in our lab in Boston. And so if there's interest, as committees work through this and discuss it, it's a place or a space that we could look at technology or look at some things we discussed. So I'm hoping we can continue that
Okay.
discussion, but I wanted to say it publicly in case folks have ideas that they can propose to you.
Okay,
Thanks.
that sounds great. Thank you. Thank you.
I'm